We are live.
Good evening.
Yes,
Dr. Bhavi, we are live.
yes. So good evening, everyone. Yes. So thank you all for joining us this evening and making this program much more interactive and successful in the future as well. So the AIS Guru Sangam program, first of all, thank you all, the esteemed panelists and the speakers for joining us and all the residents across the country to be a part of this. The AIS Guru Sangam program is an initiative by the All India Ophthalmological Society aimed at fostering mentorship and skill development among the ophthalmologists, and it serves as a platform where aspiring and early career ophthalmologists can engage with seasoned experts, as we'll see today as well. Okay, or also as called as gurus, right? The teachers. That is why the program is Guru Sangam. Through structured mentorship, interactive sessions, and hands-on workshops, this program bridges the gap between experience and innovation, and ensuring knowledge transfer across the generation. Okay. So, welcome to the 13th episode of Guru Sangam, and today's topic is UVEA. Yeah. So, before we proceed, we would like to acknowledge it and thank our chairman, Dr. Samar Basak, for his mentorship and for his aspirational leadership into guiding us for this program. Our program directors, Dr. Santosh Hunawar and Dr. Manoj Mathur, for giving us the direction to run this program and to ensure that all ophthalmologists across the country learn from the best in the country. Our expert panel today comprises of Dr. Amit Khosla, who is a senior doctor from Sir Gangaram Hospital in Delhi, Dr. Padmamalini Mahendra Das, who is an uveitis expert from Narayana Netralaya, Bangalore, Dr. Ratinam. The name itself is enough for all of us to be glued to our screens and to learn from her, from Arvind Eye Hospital, Madurai, and Dr. Samya Vasu, who is one of my teachers as well from LV Prasad Eye Institute, Hyderabad. Again, all are big names in the field of uveitis, and we are privileged today to learn from them. So, Dr. Basak, if you have joined, would you like to say a few words? Okay, I'm not sure if he's joined. Dr. Santosh?
So you can start. They're not there.
Okay, perfect. So, we'll do one thing. We'll proceed with our first talk. So we have 4 talks of 30 minutes each. Our first talk is by Dr. Vijay Pratap Singh Tomar, who completed his diploma in ophthalmology in 2007 and then subsequently a fellowship in UVEA and medical retina from Shankarnagar, Chennai from 2010 to 2012. He's an ex-senior consultant of UVEA and medical retina at Sitapur Eye Hospital in Sitapur. He's ex-professor of RIO Sitapur and a resourceful teacher for various programs by AIS in uveitis, and he has won several awards. Currently, he is in Shahjahanpur. So, over to you, Dr. Vijay, for your talk on decoding posterior uveitis. So, after your talk, we have a 30-minute session for each speaker. After your talk, we can have questions based on the talk itself. And I request everyone to write your questions on the YouTube channel so we can, from the comments, we can take those questions. Over to you, Dr. Vijay Pratap.
Thank you so much, AIOS, for giving me this opportunity. Is that coming? No.
It's the end of slideshow. You can go to the first slide.
Oh.
You can reshare it and you can just move one slide back.
That I'm doing.
Yeah. So meanwhile, Dr. Vijay sets up his presentation. Yeah.
So thank you so much, AIOS, for giving me this opportunity to interact with the.
So we are still not visible. If you can share again,
Why is
please.
not yet visible?
Is it visible now?
No, sir. You need to share again, please. Same
Okay.
step. Just click on the share button.
So in the meanwhile, Dr. Vijay is preparing his slides. I'll request all the PG postgraduates to ensure that you are ready with your pen paper. Write down the important points, and you can on the YouTube comment section you can ask your questions. If time permits, we can go back there and we can pick the questions from there. So we can see a slide, posterior uveitis differential diagnosis, Dr. Vijay.
So if you can just click on the slides and just go on the first this thing. Yes, all good, sir.
Yes, yeah,
You can
please
start,
go
sir.
ahead, sir. You are muted, Dr. Vijay. Can you restart and go to the first slide? You're muted now. Yeah, we request you to
Hello.
start at the beginning. Yeah, the first slide.
So in our day-to-day clinical practice,
Yeah.
we evaluate the patients of posterior uveitis. And sometimes it is really very easy. It's like a cakewalk to diagnose the case, but sometimes it's like a jigsaw puzzle to get the diagnosis. So before evaluating a patient of posterior uveitis, few questions should always be there in our mind that whether we are dealing with a case of retinitis, is it a case of choroiditis or a case of retinochoroiditis? Is it neuroretinitis or a case of retinal vasculitis? Whether the presentation is with the anterior segment inflammation or vitritis. What are the other systemic features which are associated with this type of clinical ocular manifestations? Whether all these clinical profile is fitting into some specific clinical entity, whether the disease is having recurrences, and if yes, how the disease is responding to the previous treatment. Now, making a life a little simpler, whether the posterior uveitis is present with vasculitis, think of basis, TB, or sarcoid. If it is a choroiditis or retinitis, think of tuberculosis or viral entities like ARN, POR, and CMV retinitis, or basis disease, toxoplasma and toxocara. If it is found to be associated with hypopion, think of basis disease or some infective etiology. If it is associated with exudative retinal detachment, think of VKH and sympathetic ophthalmia. And if there are multiple numerous dot-like lesions which are whitish or creamish yellow, think of white dot syndromes. So now coming one by one. So if we are seeing a patient who is young presenting with hypopian uveitis, with intense vitreous inflammation along with occlusive necrotizing vasculitis, predominantly involving arteries and vein, think of adamantadus basis disease. The first description of this disease was done by the Hippocrates of Cos in the 5th century before Christ in his third book of epidemiology, and later on in 1930, it was Adamantadus who presented his first paper with the ocular manifestation of this disease. And in 1937, Basitz wrote down the findings of cutaneous as well as genital lesions with iridocyclitis. And now this disease is known as adamantadus basis disease. This disease is very much common in the younger generation, that is in between the age of 25 to 35 years, and there is a little sexual predilection of males more than females. The disease is also known as Silk Route disease because this is more commonly seen in the Eastern Mediterranean countries as well as the Eastern Pacific Asia. Hence, the disease is most commonly seen in Turkey, Iran, and Japan. Basis Research Committee Japan has proposed a diagnostic criteria containing major criterias and minor criterias. In the major criterias, we have aphthous ulcers of mouth, skin lesions, genital ulcers, and ocular inflammatory disease. Whereas minor criteria is having arthritis, intestinal ulcers, which is more commonly seen in Japanese population, epididymitis, vascular diseases, and neuropsychiatric manifestations. And depending upon the presence of major as well as minor criteria, they are further divided this into the complete type of BASIS, incomplete type, BASIS suspect, and BASIS possible. Later on, International Study Group for BASIS disease also proposed a diagnostic criteria where they have emphasis on the recurrent oral aphthous ulcers. And there should be at least 3 episodes of recurrent oral aphthous ulcers in a year, along with any of the two, that is recurrent genital ulcers, ocular inflammation, dermatological manifestations, along with the positive pathology test. While evaluating these patients, we should look their oral cavity, and these aphthous ulcers can be seen not only over the lips, they can be seen over the gums, the tongue, that hard palate, uvula, and posterior pharynx. These lesions are extremely painful. Remember that oral ulcers are also seen in the patients of reactive arthritis, previously known as Ritter's disease and Stevens-Johnson syndrome. But in reactive arthritis and Stevens-Johnson syndrome, these lesions are painless. In Baser's disease, these lesions comes in the crop. They are around zero point 0.3 to 15 millimeter in size, extremely painful, creamish white, well-defined lesions with a red rim. And similar type of lesions are also seen over the genital areas. In the males, they are seen over the glans and the scrotum, whereas in the females, they are seen in the vulval and vaginal mucosa. In females, we should always differentiate these lesions from the herpetic lesions. And in females, these lesions can be painless also. Erythema nodosum lesions are seen in the Baser's disease. These are painful pustules which can be seen over the shin of the tibia as well as over the face, nape of the neck, and the buttocks. And the phenomena of dermatographism has been noted in 1/3 to 40% of the cases. Apart from these dermatological manifestations, Baser's can present as folliculitis and acne vulgaris. Now coming to the ocular manifestations. These patients usually presents with hypopian uveitis, but this hypopian uveitis is seen nowadays only in 20% of the population due to the frequent use of topical steroids. Sometimes hypopian is very small, so gonioscopy is always to be done to rule out any angle hypopian. And if any neovascularization of iris is present, it is always a poor prognostic indicator. Isolated vitritis is highly uncommon, and there is always the presence of obliterative necrotizing retinal vasculitis, predominantly involving arteries and veins both, with venous and capillary dilatation along with the engorgement. And fundus fluorescein angiography is always warranted, not only to diagnose the case as well as to know the progression of the disease. On fundus fluorescein angiography, we found dilatation or occlusion of the retinal capillaries along with the massive leakage of the dye from the capillaries, giving a typical fern-like appearance with non-perfusion choroidal areas. On progression of the disease, fundus fluorescein angiography actually shows the formation of collaterals as well as the presence of NVEs and disc staining. Basics can also present as papillitis and neuroretinitis, and because of the recurrent episodes of this disease, optic atrophy can occur in these patients. Whenever you are evaluating a patient of vascular occlusion, apart from hyperhomocystinemia and collagen disorders, always try to rule out Baser's disease. With the recurrent episodes of inflammation, there will be the sheathing of the vessels along with the RPE alteration, and later on choroidal scarring can be seen in the recurrent episodes of the disease. Before pinpointing the basis, always rule out the other causes of vasculitis and always ask for HLA-B51 testing. But sometimes, like in the only ocular manifestations of the basets are present and systemic manifestations are absent, always order HLA-B5. Likewise, whenever that mucocutaneous lesions are present, HLA-B12 is found to be positive, and in the cases of basets arthritis, HLA-B27 is positive. Systemic corticosteroids, immunomodulatory agents, and biologicals are the mainstay of the treatment. Whenever we see a patient of posterior uveitis with predominantly retinitis and vasculitis, think of ARN. If you are seeing the few or multiple areas of peripheral retinal necrosis, which is spreading circumferentially in the absence of antiviral treatment. Remember the word circumferential spread in the absence of antiviral treatment. And these lesions gives a typical Swiss cheese appearance. The lesion starts healing from the periphery and later on there will be a salt and pepper type of hyperpigmentation in the fundus. The disease is characterized by the presence of moderate to severe vitritis along with the retinal necrosis and occlusive retinal vasculitis predominantly involving arterioles as a sine qua non for the ARN. They can also present with hypotony due to the ciliary shutdown, or they can have raised IOP due to the involvement of trabecular meshwork. They present with severe vitritis and vitreous exudates. The retinal inflammation is so much that the retina looks like a sieve, and because of this retinal atrophy, they can have multiple retinal tears leading to the rhegmatogenous retinal detachment. Always have an eye on the other eye because the disease can involve the other eye too. Always have a history of any prodromal viral fever and look for the telltale sign of chickenpox and herpes zoster vesicles. The diagnosis is mainly clinical, but it can be confirmed by the means of PCR analysis of aqueous and vitreous. Goldman-Whitmer coefficient of more than 3 is diagnostic of ARN, and when it is combined with the PCR, it gives a good diagnostic yield. Retinal biopsy is indicated in the cases of diagnostic dilemma. The first description of ARN was given by Kirisawa. So this disease is also known as Kirisawa uveitis, and the disease is seen in healthy and immunocompetent patients. The disease is caused most commonly by varicella zoster virus, followed by herpes simplex virus, CMV and EBV, and systemic antiviral therapy in the form of acyclovir or famciclovir or valacyclovir along with the steroids. But the role of steroids in prophylactic laser barrage is always controversial. In the case of retinal detachment, surgery is warranted. The progressive outer retinal necrosis is characterized by the severe multifocal deep dense retinal necrotic lesions, which are predominantly involving posterior pole, but leaving the vessels giving a typical cracked mud appearance. The disease is usually seen in immunocompromised patients, particularly the patient who are having CD4 count less than 50, and there is minimal or no vitritis. Because of the retinal and optic atrophy, the prognosis is very poor despite treating all these patients even with the two antiviral agents. Cytomegalovirus retinitis is more commonly seen in immunocompromised patients, particularly whenever their CD4 count is less than 50, and there are the three distinct patterns. The first pattern is the classical or fulminant hemorrhagic necrotizing retinitis, where there is multiple exudation and hemorrhages seen at the posterior pole involving the major vascular arcade. The other form is the granular indolent form, which is seen in the periphery without any marked retinal edema and hemorrhages and exudation. Third form is again a fulminant one, which is known as protrusive branch vein like anxiety, which involves perivascular area. The mainstay of the treatment of CMV retinitis is heart therapy in the patients of AIDS, along with intravitreal ganciclovir or oral ganciclovir. Now, if the posterior uveitis is presenting with choroiditis and vitritis in a patient who is presenting with the solitary posterior pole or peripheral lesion with the dense vitritis, giving a typical fog headlight in the fog appearance, think of toxoplasma. Toxoplasma retinochoroiditis is the most common infectious cause of posterior uveitis in immunocompetent patients, and it can be congenital or acquired. Acquired toxoplasma retinochoroiditis occurs when a patient is with the contact of with the pets or he is having a history of ingestion of contaminated food or water. The congenital form occurs by transplacental transmission. The least risk of transmission is seen in the first trimester where it is suspected to have in 15 to 20% of the cases. In the second trimester, the chances are 30%, and the highest risk of transmission is seen in third trimester, that is around 60%. 90% of these cases are asymptomatic, and Sabin's tetras had been seen in these patients, which is having microcephaly or hydrocephalus, mental retardation, intracranial calcification, and a healed retinochoroidal lesion of toxoplasma. Antenatal diagnosis can be done by the means of PCR and ELISA or indirect fluorescent antibody test of amniotic fluid, or by the means of ultrasound abdomen of the mother, where we see the enlargement of lateral ventricles along with the intracranial calcification. Postnatal diagnosis is done by the means of IgM antibodies, double sandwich ELISA, anti-P30 IgA antibodies. The diagnosis is mainly clinical and ELISA is non-confirmatory. PCR and Goldman-Whitmer coefficient is very much helpful. If the Goldman-Whitmer coefficient is more than 4, it is diagnostic of toxoplasma retinochoroiditis. 7-Fielman dye test is the gold standard, but now it is not done because of the chances of getting infected of the lab technicians. Anti-toxoplasma treatment in the form of a 1-sulfur drug with one non-sulfur drug along with the steroids is recommended for these patients. Suspect toxocara if your patient is having the history of contact with the puppies or there is the history of pica. The toxocara presents as a granuloma in the peripheral retina and vitreous, or they can present as a posterior pole granuloma. Sometimes they can present as chronic endophthalmitis. Sometimes the parasite invade the optic nerve and can present as optic neuritis, as well as they can present as anterior segment involvement. ELISA with toxocara secretory antigen IgE helps in diagnosing the disease. Goldman-Whitmer coefficient, when combined with ELISA, it gives a good diagnostic yield. USG and CT scanning should be done in these patients because retinoblastoma is a mimicker of this toxocara. But this calcification is seen only in the retinoblastoma and not in the cases of toxocara. So that can easily be clinched on CT scanning. Systemic steroids along with antihelminthic drugs like thibendazole, albendazole, and mebendazole is required to treat these patients. If your patient is presenting with posterior uveitis along with exudative retinal detachment, think of Faulkner-Harada disease, sympathetic ophthalmia, multifocal choroiditis with panuveitic syndrome. But the question that should come in our mind is that whether the disease is unilateral or bilateral, is there any history of trauma is present? Is there any associated choroiditis? And the disease is recurrent or not? So if you are seeing a patient who is having bilateral granulomatous uveitis with hyperemic disc with multiple subretinal fluid pockets along with the vitritis, think of leakage. These patients usually presents with the prodromal symptoms of viral illness along with the neurological manifestations as well as auditory manifestations in the form of tinnitus, dysaceusis, vertigo, and meningismus. Dermatological involvement is usually seen in the chronic form and they can present as vitiligo, poliosis, and the loss of hairs. Fundus fluorescein angiography helps us in diagnosing these patients, and in these patients, we will see the early pinpoint leakage along with the pooling of the dye in the late phase and staining of the disc. On ultrasound B scan, there is increased retinochoroidal thickness along with the shifting fluid phenomena suggestive of serous retinal detachment. And on OCT, multiple neurosensory detachments has been noted in these patients. It's a multi-system autoimmune disorders which principally affects pigmented because what happens, the T lymphocytes are directed against the melanocyte containing tissues, that is skin, hairs, ocular, RPE, auditory, and CNS. And the disease is having 4 stages: prodromal stage, acute uveitic stage, convulsant stage, and chronic recurrent stage. The sunset glow fundus and perilimbal vitiligo, that is Sugiura sign, is seen in the convalescent stage. And the mainstay of the treatment is systemic steroids along with immunosuppressives and biologicals. If the patient is having similar picture but is having the history of trauma, think of sympathetic ophthalmitis. Initially, the eye which is injured is known as exciting eye and the other eye is called sympathizing eye. And initially, the patient presents with mild visual disturbance along with the near vision compromise due to the change in the accommodation. They also have pain and redness. Later on, they have significant visual loss. The time from injury to onset is usually less than 3 months in 80% of the cases, and in 90% of the cases, it is within 1 year. But there are case reports where sympathetic ophthalmitis has been reported as early as after 5 days and as late as after 66 years. There are many etiopathogenesis behind this disease. Thanks to the biologicals and immunosuppressive agents, because of them, now we can salvage the eye. But if the eye is not we cannot salvage the eye, early enucleation of the injured eye should always be done. It is really sometimes difficult to differentiate between SO and VKH because their clinical presentations are similar, but there is no history of ocular injury in VKH. VKH patients usually present with systemic manifestations, which are uncommon in SO, and Gallen-Fuchs nodules, they can be present in VKH, but more commonly they are seen in sympathetic ophthalmitis patients. But there are certain masqueraders, like posterior scleritis, but it is easy to diagnose them because there is pain in the patients of posterior scleritis, particularly when they move their eyes, and posterior scleritis is usually unilateral. The FFA picture is almost same, but on ultrasound, we can get a T sign in the patients of posterior scleritis. Multifocal CSCR is again a big masquerader, but there is no inflammatory cell either in the anterior chamber or in the vitreous. There is no pain, and on fundus fluorescein angiography, we get that typical ink blot or smokestack pattern. Since we are living in a country where TB is endemic, so TB should always be ruled out in the patients of posterior uveitis. TB can present like anything. They can present as few to multiple choroidal granulomas ranging from 1/3 disc diameter to 1 disc diameter. Sometimes these choroidal granuloma can be solitary and they are as larger as 4 millimeter to 14 millimeter in size with severe exudative retinal detachment mimicking as subretinal abscess or intraocular tumor. Tuberculosis can present as serpiginous-like choroiditis and they can also present as retinal vasculitis. Mantoux test should always be ordered, but if Mantoux test is positive, it doesn't mean that the patient is having TB. Because in a country like India, where everybody is having BCG vaccination or some sort of exposure to the TB, this Mantoux test is going to be positive. But if Mantoux test is negative, it doesn't mean that TB is not there, because in severe immunocompromised patients or in the cases of miliary tuberculosis, Mantoux test can be negative. So it should be confirmed either by the means of chest X-ray and CT scan of the chest. Quantiferon TB gold test should be done in these patients, and PCR using MPB64 gene helps us in diagnosing the tuberculosis. The real-time PCR helps us in excluding the contaminants and the commensals. ELISA and PCR of the serum is not useful in the endemic countries like India and should not be the basis for the diagnosis of ocular tuberculosis. Sarcoid uveitis is again a mimicker of tuberculous uveitis. They can present as multiple granulomas as well as solitary granulomas and can cause retinal vasculitis. But the pattern of retinal vasculitis in sarcoidosis is that there are the skipped areas which are not having any inflammation, giving the tachys in the boogie. And there are candle wax drippings seen in the patients of sarcoid retinal vasculitis. Sarcoid can present as solitary granulomas, particularly in the periphery. Sarcoid can also present as neuroretinitis and can mimic as papillitis. For the systemic manifestations, we should always look for erythema nodosum and look for the lupus pernio, which are actually the purplish plaque-like lesions seen over the shin of the tibia. Mantoux test is negative in the patients of sarcoidosis due to the cutaneous energy, and on X-ray chest we get the bilateral hydral lymphadenopathy along with, and on the CT we get the beating of the vessels. Raised serum ACE titers has been seen in sarcoid, but its interpretation should be very cautious because these titers can be seen raised not only in the sarcoid but can also be seen in the patients of TB, syphilis, pregnancy, chronic smokers, and children. Serum lysozyme test should always be done in these patients, and LFT should always be ordered. If the titer of serum alkaline phosphatase is 3 times higher, along with the twice rise of the titers of any of the two, that is SGOT, SGPT, and gamma glutamyl transferase, it is suggestive, it is helpful in diagnosing the sarcoid. And on bronchoalveolar lavas, the CD4 CD8 ratio is found to be inversed. Histopathology is the gold standard to diagnose these patients. Syphilis, which is also known as French pox, is a great mimicker, and it can mimic as ARN, it can mimic as white dot syndromes. The main presentation of syphilis is chorioretinitis, but sometimes they can involve the peripheral retina with the retinal necrotic areas mimicking as ARN. Sometimes they can involve the inner retina in the punctate form mimicking as white dot syndromes. RPR and VDRL should always be done along with the FTAABS or TPHA, because VDRL and RPR is having lower titers when this troponin is inactive, that is in the phase of latent syphilis, or the patient has been successfully treated for the syphilis. But FTAABS or TPHA, once it is positive, it will remain positive despite the treatment, and it should be treated as a case of neurosyphilis. Now, coming to the white dot syndromes, it is really very difficult to cover up all the white dot syndromes due to the constraint of time. So, white dot syndromes are a group of ocular disorders which are characterized by the presence of whitish lesion in the choroid, retinal pigmentary epithelium, or sensory retina. And there is a long list of these white dot syndromes starting from the APMPP to bloodshot chorioretinopathy. I will take care of only few cases which we see in our day-to-day clinical practice as a UVEA consultant. So the first is acute posterior multifocal placoid pigmentary epitheliopathy. And as the name suggests, we get multiple round circumscribed flat yellow placoid lesions of 1 to 2 disc diameter at the posterior pole at the level of RP, which are extending up to the equator. The disease is seen usually in the age group of 20 to 40 years without any sexual predilection, and the disease is mostly bilateral. Mild to moderate degree of vitritis is seen in 50% cases, and on fundus fluorescent angiography, we get early hypofluorescence because of the blockage and late hyperfluorescence because of the staining. The lesions appears more on FFA as they are seen clinically. The multiple evanescent white dot syndrome, it is characterized by the presence of multiple small, round, slightly indistinct lesions, which are whitish to yellow, predominantly seen in the perifoveal and peripapillary region. The disease is more commonly seen in females and usually unilateral and seen in young patients, and best diagnosed by using the slit lamp biomicroscopy with the 78D or 90D lens, and uniform macular granularity is the pathognomonic of mutes. On fundus fluorescent angiography, the lesions are early hyperfluorescent, giving a rat-like configurations, and again they are more in number than they are seen clinically. The
Dr. Vijay, if you
serpiginous
can
choroiditis
conclude
usually affects,
in the next
binding up, sir.
minute or so. Yeah.
Usually affects the age group of 30 to 60 years. This is bilateral, and the lesion starts near the disc, leading in a serpentine manner and running in a centripetal manner, and they are seen at the periphery. And fundus autofluorescence is a good tool. The active lesions shows hyperautofluorescence, and the heel lesions show hypoautofluorescence. Multifocal choroiditis is seen more commonly in younger females. This is bilateral with mild to moderate non-granulomatous anterior uveitis with vitritis, a distinct propensity for a peripapillary and nasal mid-peripheral and peripheral distribution of these lesions has been noted, and optic disc involvement is seen in 1/3 of the cases. Rule out TB, syphilis, PUHS, DUSN, and viral retinitis in these patients, and steroids and immunosuppressive agents are used. The punctate inner
Dr. Vijay,
choroidopathy
can
is
we
seen in
conclude?
young myopic women, and this is bilateral. Lack of anterior uveitis and vitritis is the hallmark of PIC, and there is no presence of CME or disc asthma as opposed to the MFC or mutes.
Dr. Vijay, I will request that we can. Yeah, thank you. Yes. Yeah.
So the clinical history, meticulous systemic evaluation, detailed ocular examination, and tailored lab investigation is a must. And these are my acknowledgements. I am
Yes.
very much thankful to Dr. JB who has permitted me to use his clinical photographs. Thank you so much.
Yes, thank you so much, Dr. Vijay, for an extensive presentation on decoding posterior uveitis, covering both the infectious as well as the non-infectious entities. We'll quickly move on to the panelists in terms of Dr. Amit, Dr. Padma, Dr. Ratnam, and Dr. Basu. Uh, I will begin with one question here. Say for a postgraduate ophthalmologist who has a dilemma when he says in his clinic there is vitritis. So how to approach a patient with vitritis with a yellow lesion in the fundus? The patient has vitritis and he or seeing also yellow lesion. So for an ophthalmologist or a postgraduate, it might be difficult to understand whether it is infectious, non-infectious, whether you have to go for medical treatment or do a biopsy. If we can start with that question. So maybe Dr. Padma, you want to, since you're unmuted?
Sure. So whenever you have vitritis with yellowish lesions in the fundus, it indicates there is an active posterior uveitis. We need to differentiate the yellowish lesion, whether it is retinitis, a choroiditis, or retinochoroiditis. How do we differentiate? The retinitis is yellowish white, fuzzy margins. They will have sometimes can be associated with retinal hemorrhages, and these are the things. Can have associated disc edema and other stuffs. Whereas in choroiditis, they are again well-defined yellowish lesion. We can see the vessels crossing over the lesion. That indicates its possibility of choroiditis. Sometimes if you have outer retinitis, we may not be able to differentiate. So when you have significant vitritis with retinitis, again you have to differentiate whether it's a unifocal lesion or a multifocal lesion. If it is unifocal, toxoplasmosis comes top in the differential diagnosis. Or if it's multifocal, the viral comes. When it comes to non-infectious, the entity which has been already described very well by Dr. Vijay Tomar, non-infectious multifocal retinitis is a Behçet's disease. There, we may not have significant vitritis, but can have associated vasculitis with systemic features. So based on that, you put the differential diagnosis and based you can ask the relevant investigation.
Okay, thank you, Dr. Padma. Dr. Ratnam, if we can have your views on differentiating infectious versus non-infectious posterior uveitis based on clinical signs, because that is what a postgraduate is going to encounter before sending for investigations.
Yeah, actually, as the speaker mentioned, whenever it is a unifocal or multifocal retinitis, most of the time it is infectious. Whereas exudative RD and chorioretinal thickening, it is a non-infectious like PKH.
Okay.
And other associated systemic findings. The only entity where people get confused is white dot syndrome. As speaker mentioned, there are so many white dot syndromes, but they are morphologically characterized. So once we see AMPP once, we will never forget it. So retinitis choroiditis is infectious. Exudative RD and chorioretinal thickening is PKH and seborrheic ophthalmia. So with the associated symptoms, systemic symptoms, definitely we can come to some conclusion.
Yes, thank you, Dr. Ratnam. So my next question, Dr. Soumya Basu and Dr. Amit Khosla. The first part of the question is, what is the first line investigation panel that you will consider to understand whether you're treating in terms of or diagnosing in terms of infectious or non-infectious uveitis? Is Dr. Amit first?
So normally in a localized eye infection, you may not have any systemic findings of blood test to be positive. So it's a clinical diagnosis, and if you find it, you can use correlative. India, tuberculosis is the commonest. As you mentioned, choroiditis can also be tubercular. So the exception to the retinitis was non-infective is Behçet's, and choroiditis TB is the infective part. So in India, you always get a X-ray chest or a Montus done because you feel 1 in 100 is going to be TB. But they have want to highlight that CT scan is much more diagnostic for TB because we tend to find lymph nodes more common. Bacillary TB until you have a miliary TB or you have a big granuloma where you find tuberculosis. So blood tests are really going to be positive, but if you plan to give steroids, so all the blood tests which you require to give steroids or will be required to be done.
Okay, thank you, Dr. Amit. Dr. Basu, would you like to add to the investigations? Is the first question, and to Dr. Padma as well. And the second question here to you, Dr. Basu, is that when will you consider diagnostic biopsy in such cases? I don't know if Dr. Basu is connected. Dr. Basu? Okay, if not, Dr. Padma, would you like to take up that question?
Regarding the biopsy, you're asking?
Yeah, and see what happens sometimes, you know, that is dense vitritis and there is a yellow lesion. You're not sure it is toxo or it is endogenous endophthalmitis, right? Because in India, most of the patients of endogenous endophthalmitis do not have a precursor illness or a fever as well. So that is where the confusion is, because if it's infectious and you start steroids, it's going to worsen. So my question, so that to precaution all the ophthalmologists, postgraduates especially, that how you have to approach in a stepwise manner.
Okay. The first, when you see the clinical appearance, you are suspecting it is an infective uveitis. You try to look for any systemic association, whether the patient has any systemic disease. As you told, most of the times they may not have obvious systemic findings. The next comes in the ocular. When you're not there, the next, the imaging comes into rescue, especially to differentiate certain etiologies. When you have a yellowish lesions, you pass through the OCT. It will tell us whether it's retinitis or choroiditis or retinochoroiditis based on the specific. For example, if you're suspecting a fungal infection, sometimes we can, due to candidiasis, we can get a rain cloud sign where the lesion comes from the choroid, pass through the full retina and present in the vitreous cavity, suggest it is an infective etiology. In that situation, definitely a parsonal vitrectomy with that lesion, like, that will give us a clue, especially when you are suspecting an endogenous endophthalmitis, probably a fungal we are suspecting in that case. The
Yeah.
next, you have retinochoroiditis. The lesion keeps coming and then disappearing. You give steroids, you get the partial response, and if it's a creeping course, could be a masquerade such as intraocular lymphoma. In that situation, also, the biopsy will help us to confirm the diagnosis. We don't jump and do the biopsy. First, you see the clinical evaluation, try to get the systemic findings. If you get the systemic clue, you go ahead with the treatment. Then the laboratory and the imaging methods plays into the picture. If the patient, you are not able to find the clue, you're suspecting highly an infective etiology or extremes of age group with masquerades, then the biopsy help us to confirm the diagnosis.
Okay. Thank you, Dr. Padma. So, Dr. Biswas, you want to summarize in a minute important points for an ophthalmologist, postgraduate ophthalmologist?
So when I look at a patient of uveitis, I first see that whether it's infective or non-infective. That's my first approach.
Yeah.
And then I look into it, whether it's an active or inactive. And then lastly, I think whether I'm missing a muscular syndrome or not. This is the way of my approach.
Yeah.
And as Padma is very rightly told that most of the cases of retinitis is an infective, either viral except Behçet's disease, where it can be focal or multifocal retinitis can be seen. So when you see a retinitis, you would be always consider a high possibility of infective retinitis, and do the test for the same. There is one entity one should be remembering in our setup, which has not been touched upon, is the post-fever retinitis. That's also a very important in our part of the country, world. We see a lot of post-fever retinitis. So good history taking would be very important to see these cases and do appropriate treatment for the same diagnosis and treatment.
Yeah. Thank you. So what we have understood here, to summarize, is an approach to a patient with posterior uveitis, differentiate between infectious, non-infectious. Start investigate the individual. If required, you may need a vitreous biopsy as well. At the same time, based on investigations, you carry on with the treatment. The treatment consists of, for infectious, the appropriate antibiotic agent and steroids for the non-infectious part. But for a few of the patients, steroids may not be sufficient for non-infectious etiologies. In such cases, we may have to use certain biologics. And our second talk is by Dr. Jyotirmay Biswas, who is going to speak upon the role of biologics in uveitis. So if I have to introduce Dr. Biswas, this one slide itself is not sufficient. He's an ophthalmologist who is specialized in uveitis. We know that, and more importantly, ophthalmic pathology as well. He has done a fellowship from Shankar Nitalaya and from Doheny Eye Institute in Southern California. He has published extensively, and we are aware of all his papers, textbook chapters, everything on uveitis and pathology. More importantly, it's not just about diagnosing. He has been teaching different fellows, 48 uveitis fellows until now, and through which he is able to conquer uveitis across the country. He has received several awards, including Hariom Ashram Alembic Research Award from ICMR, and he is the first one to describe ocular lesions in AIDS in India. With this, I invite Dr. Biswas for his talk on biologics and uveitis. Only one request to all the speakers: if we can finish in 30 minutes, we can have a good discussion of 15 minutes. Dr. Biswas, over to you.
Yeah.
So you're going to learn a lot to all ophthalmologists from this talk, no doubt about it.
Good evening.
Yes.
I feel extremely honored and humbled by talking in this GuruSangam program, which is a unique program. I make my talk for the postgraduates, and I'm aware of that distinguished panelists which we are privileged to have them with us: Dr. Padma Malini, Dr. Ratnam, Dr. Somabha, and Dr. Amit Khosla. So in front of them, I'm sharing my talk. I'll be talking on those things which I have practiced only. So there are a lot of biologic agents has been in the market and in use, which I have not used. I'm not talking about them. Let me start with a case. This 28-year-old male came from Chennai to my outpatient department on 2022, and he complained of marked blurring of vision in both eyes. As Dr. Ratnam was talking about it, that you need to take the patient as a whole. And this patient has a recurrent oral aphthous ulcer and also had leg ulcer, which you call erythema nodosum. And had vision was very poor. He was treated elsewhere with oral steroid, no improvement. Let us look at the picture, and you can see that the vision in the right eye is grossly diminished, 660, and in the left eye, 624. Patient was given subcutaneous injection of adalimumab once in 2 weeks for 80 injections. Vision in the right eye improved from 660, this is a before treatment, and this is the after treatment, to 69, and oral and leg ulcer got healed. What the patient was received was adalimumab, was a biologic agent, which showed dramatic improvement. Let's see another case. This is a doctor from Manipur. He was in one of the medical colleges in Chennai. A 38-year-old lady, redness, pain, dimness of vision in the right eye for 20 days. He's a known case of reactive arthritis. She was on tablet methotrexate, 15 milligram per week, and tablet sulfasalazine, 1 gram, 1 time, 2 times daily. Basic visual acuity was 6.9 right eye, and left eye 6.6 and 6 in 8 in the right eye. What the patient was having was a severe hypopia, a severe fibrinous reaction in anterior uveitis, essential 3 pairs, broken posterior synechia, fine keratic precipitate. And his lab investigations, as Padma was telling, that we should do lab investigations first, that HLA-B27 is positive, anti-nuclear antibody, anti-CCP RF factor negative, CRP was 14, and ESR was high, MANT was negative, chest X was normal. He started on topical steroid, cycloplegic and oral prednisone, 60 milligram and tapering doses over there. What I did, The patient had so severe inflammation. I added injection adalimumab, 40 milligrams subcutaneously every 2 weeks after the rheumatologist clearance. And look at the picture. After first dose of injection adalimumab, there's a marked reduction in inflammation. Of course, the patient was treated with topical steroid and mediatic cycloplegic agent, continued to improve on treatment. After 6 months, adalimumab was stopped and the patient got back vision. These two cases indicate the biologics has emerged in some cases of uveitis, and I'll be talking a little bit about the scleritis also. Outline of the talk is that I will go back to the history of evolution of the drugs, treatment strategy for non-infectious uveitis and scleritis, where biologics stand, what are the biologics, how do they act, classification of biologics, where they can be used, or experience with biologics, workup before starting biologics. History is 1950 was a landmark period in the management of anti-inflammatory treatment when Gordon published his work on oral steroid in usage of prednisone in usage of as an anti-inflammatory drug. In 1966, von Wang from Washington used methotrexate to manage ocular inflammatory disease. It took about 30 years, after almost 30 years, when the first immunobiologic agents was used, that is CMT412 and etanercept. And these were the drugs and which has recently been popularized and has made a great change, game changer in uveitis treatment. So treatment strategy today still stands for the corticosteroids as a mainstay of treatment, which can be given in the topical, oral, intravenous, posterior subteral, intravitreal injection, and today nowadays various types of implants can be used. Immunomodulator agents, we know that they are very useful. Methotrexate, mycophenolate mofetil, azathioprine, cyclosporine. But lastly, the new drug which has come, biologic agents, but we need not jump to biologic agents as the first line of treatment in many of the non-infectious uveitis cases. What are the biologics? Basically, the biologic, simplified, is a biologic response modifier. They're born of recombinant DNA technology and the blocks activity of bioactive mediators like cytokines, etc., of the immune response. So there are several biologics, TNF inhibitors, TNF alpha inhibitors, anti-interleukin, CD20, B-cell directed, co-stimulatory blockade, and interferon. Of these, the TNF inhibitors are very commonly used, as well as the interleukin-6, there's etanercept, which is not used nowadays, infliximab, adalimumab, golimumab, and sartolizumab. Anti-interleukin, as I told you, is the tocilizumab, of which I have got experience of using it. Rest of the things I have not used it. I'm not talking about that. And CD20 B-cell directed antibody is a rituximab, which I have used it. So these are the drugs which have been used. They're the alternative in inadequate response. Today we have got them and we can use them. Intolerance to conventional immunotherapy, and most important thing which I want to highlight to you, these are the first-line therapy in certain conditions like Behçet's disease and JA-associated uveitis in many situations. So patient today is conscious and they might ask you that why don't you use these biologic agents on. July 2016 was a landmark day, landmark year, where adalimumab received the USA FDA approval and treat adults with non-infectious intermediate, posterior, and panuveitis. And adalimumab is one of the very common drugs used in medicine. So where the biologics act, these anti-TNF alpha act on the cytokines levels in the cytokines, various anti-inflammatory molecules, which from the Th17 cells liberates, which acts on there, or an anti-IL-6 inhibitor, it acts on the interleukins over there. Where they indicated over the one, nowadays, I am using many of the patients, if I have got an option to use it, is Bass's disease is my first choice. It's a blinding disease where biologic agents make a lot of difference. Second disease where I use it is JA-associated uveitis. And third is the HLA-B27 associated uveitis, which is recalcitrant associated with the systemic disease. I've used injection adalimumab. Bloch syndrome, recalcitrant non-infectious uveitis, and recalcitrant scleritis. So Bass's disease, and I do not go in details about it, is a cold mobile white hypopyon which is sometimes seen, and they can have severe vasculitis, arthritis and phlebitis, and retinitis. And these patients can have dense vitritis also is seen. And they have other one, you have to have an oral aphthous, recurrent oral aphthous ulcer to have this disease called Bass's disease. And genital ulcer, erythema nodosum, dermographism, these are the systemic features. J-associated uveitis is the most common childhood rheumatic disease where also we use adalimumab or infliximab. Most prevent systemic disorder in children with uveitis, arthritis at least 6 weeks of duration without any identifiable cause in children younger than 16 years. We label it as GIA-associated uveitis. Why it is important? 10 to 20% of the patients in this disease can become blind due to GI-associated uveitis. We ophthalmologists has got an important role to play. They develop chronic anterior uveitis, DSK, glaucoma, vitritis, CME, disc edema, hypertrophic maculopathy, and phthisis bulbi even. The cumulative incidence of uveitis is quite high, 8.5 to 2.5% in various studies. And then Dr. Professor A.V. Ramanan published a landmark article in 2017 when he showed the adalimumab plus methotrexate for uveitis in juvenile idiopathic arthritis has got a significant beneficial effect and could be used in salvaging the vision of this patient. How are they used? Infliximab and rituximab is intravenously used, and adalimumab and golimumab is used subcutaneously. I'll be talking about a little bit of dosage at the end. Biologics and uveitis, my experience, our center's experience is that we have used mostly adalimumab, which I'll be talking to you mostly. And this is published recently in December 2024. Adalimumab effective or adalimumab non-infectious pediatric uveitis, 29 eyes from a tertiary eye care center in South India. And we did a study for 6 years and 29 cases, and most of the patients has got JIA, Bass's disease, BKH, and Crohn's disease. Inadequate response to immunotherapy was the indication, intolerant to immunotherapy and corticosteroids, and for control of primary systemic disease, we have used biologic agents. Criteria for the treatment success: control of inflammation, significant decrease in the disease recurrence, and the vision improvement and vision stabilization. This is the 29 eyes of 16 patients, age group 9.4 to 3.8 years, and female was common. The average number of adalimumab injection was given over 20. And here is a case of GI-associated uveitis. You can see that there is a redness of the eye, circumciliary congestion, acute anterior uveitis, and this patient has got complicated cataract. The patient was put on the injection adalimumab and subsequently even undergone a cataract surgery with intraocular lens implantation, and then the patient did very well. This is another case, VKH, recalcitrant, responded with, you see that serous-retinal detachment, subretinal safety, and responded extremely well with the treatment. Foveal contour is maintained. So disease inactivity achieved in 97.7% eyes, and disease remission was 70.4% eyes at that month. And many of the patients where the steroid was stopped or reduced to 25 milligrams daily. BCVA improved 0.48 to 0.20, which is a very significant amount of improvement was observed. Improved in 55.2%, 34.5 eyes vision maintained. Vision worsened in 10.3 eyes. But if you look at that one, there's no systemic infection or adverse reaction to the drug in this series of 29 cases. Of course, later on, we have seen few cases of reactivation of the tuberculosis. One child receiving concurrent adalimumab and methotrexate developed raised liver enzyme in well. The complications, why final visual outcome did not improve? Lot of patients, 37.9% patients had cataract or central band-shaped keratopathy, and caudal neovascular membrane was seen in two eyes. There's a 6.9% eye. Ocular hypertension is 24 eyes, and hypotony was 30.4% eyes. Although we have 10% cases where the vision did not improve, significant percentage of the patients has made a major impact with these biologic agents. Conclusion, adalimumab was found to be effective in the treatment of non-infectious uveitis. Drug was well tolerated and found to be safe, but further large-scale randomized controlled trials are warranted. Our latest work on basis uveitis also shows the similar features. When you use these patients and the steroid and immunosuppressive, beyond steroids alone, if we use, then we have found that they have not improved much. We have used 40% of the cases is steroid, immunosuppressive, and biologic agents, and another 40% steroid and immunosuppressive agents. And if we look at that patient, that adalimumab was used in the 27 patients, and 3 patients as used infliximab therapy in basis disease. And look at the vision. And here is the case before infliximab therapy, and this is after infliximab therapy. And the vision improved from 0.499 to 0.132, which is a very significant improvement. And before treatment, after treatment, we have used a golimumab in one case. This is not our study, but golimumab as a subcutaneous injection has also found to be beneficial. Can it be used in the HLA-B27 associated uveitis? Dr. Parthapratim Datta Majumdar from our center has done an elegant study. He used anti-tumor necrosis factor alpha agents in the management of HLA-B27 associated uveitis. 14 patients, and many of the patients had systemic association of ankylosing spondylitis, where the patient did not only improve the uveitis or his systemic condition, their systemic condition also improved, that arthritic conditions like ankylosing spondylitis became better. Bloss syndrome is a rare disease where you can get arthritis involving interphalangeal joints, and maculopapular dermal rash can be seen. And these patients can have granulomatous uveitis with Busch's nodules, Kopi nodules, very chronic, severe recalcitrant uveitis. But with the use of adalimumab, we found a significant improvement of the vision. At 2 years follow-up, I was quite with good improvement of the vision. This has been published in Indian Journal of Ophthalmology in 2018. VKH, can be biologic agents can be given or not. In recalcitrant cases, there are several studies has shown that this has been found to be useful. We are yet to analyze our data, but we have found that VKH can, recalcitrant VKH cases, biologic therapy is an option. Non-infectious uveitis and scleritis, we have 2020, we published 18 cases, adalimumab 61%, majority of the cases, infliximab 12%, rituximab 12%, and golimumab 16%. Prednisolone dose can be reduced from 30 mg to 55 mg of the biologic therapy. As you know, prednisolone can produce multiple side effects of various, and which might sometimes be unacceptable also, and this can be reduced, doses can be reduced, thereafter side effects also can be reduced. Tocilizumab in uveitis is another one, and we have used in central macular thickness. This is a case which I published in Inflammation Journal. Successful resolution of refractory cystoid macular edema following tocilizumab therapy in a case of severe recalcitrant juvenile idiopathic arthritis associated uveitis. This particular patient, 6-year-old girl, in 1999 we came, and that time we did have a methotrexate only. Later on, when biology came, we gave infliximab, then did not respond. After that, become resistant. Then we give adalimumab, developed recalcitrant cystoid macular edema, and you can see that there's a huge cystoid macular edema in the right eye, and this responded extremely well with the after tocilizumab therapy. Rituximab is a monoclonal antibody against antigen CD20. It is given intravenously, alternative to refractory uveitis cases not responding to the direct dose is 1,000 milligram dose. Is a good inflammation, good option in the diffuse subretinal fibrosis uveitis syndrome, which is a blinding disorder. Is a beat CD20 antibody blocker, and it can be found to be useful in scleritis, recalcitrant scleritis, after including B-cell monitoring. So what are the screening? How do you start biologic therapy? What are the precautions? We must do a complete blood count, ESR, CRP, liver function test, urine routine, and microscopy. Most important is the Mantoux test and IGRA in our country, like quantified TB gold test is important. A patient is having active TB, you should not give that one. If quantified TB gold test positive, then you have to give that treatment for 90 days of anti-TB treatment with INH, and then the patient can be given treatment for the biologic therapy. Hepatitis B surface antigen, anti-hepatitis B antibody, anti-hepatitis C antibody, and ELISA for HIV should always be done. And this is what I told you is a game changer in the uveitis treatment. Now I will touch upon the JAK inhibitor which we are using. Dr. Pasapratin, Dr. Mujumdar has studied in the toxicity extensively in our center, and we have found that successful 9 out of the 10 cases recalcitrated to or intern to conventional therapy. And this is a case which I have seen. This is a patient of scleritis with peripheral keratitis and responded elegantly with necrotizing scleritis with the treatment with tofacitinib. Dosage and adverse effects. This is found in the textbook. I just don't want to talk about it. And let's skip this one. The golimumab, cetuximab, B-cell inhibitor, tocilizumab. Tocilizumab is 4 to 8 milligram per kg IV every 4 weeks. Or 100, we give subcutaneous injection, 162 milligrams subcutaneously every 1 to 2 weeks. Janus kinase inhibitor, tofacitinib, and 5 milligram twice daily. There can be herpes, the reactivation of the herpes virus infection can be there. Now, regarding which is a practical in our country, the cost of this treatment. This drug is definitely much costlier than steroid and immunosuppressive agents, and adalimumab per year costs 1,88,000 rupees, and infliximab is more than that. And there is a solution to that one. Nowadays, the cost has come down quite a bit with the usage of biosimilar, and nowadays we are using mostly biosimilars, and these are equally effective than the biologic agents, original biologic agents. Can biologic be used in pregnancy? I'm not very sure, but what the literature has found that they are not increased risk of miscarriage or congenital malformation is there. But I have seen in the recent literature that their American Rheumatology Association said that to continue the pregnancy with the biologic agents. So I am not advocating the biologic agents in pregnancy. So to summarize, take-home message is biologics has definitely emerged as a new weapon in the armamentarium management of non-infectious uveitis. Remember, it's a non-infectious uveitis. It works best in the basis and GI-associated uveitis. That's my experience, but needs more data, needs precautions before starting therapy, not without side effects, and is costly, and that has to be taken care of. Thank you very much.
Thank you so much, Dr. Biswas, first of all, for finishing your talk in time and for that in-depth analysis of biologics in cases of non-infectious uveitis. So we'll start off with the question first, which Dr. Apurva has asked in the chat. This is for all the listeners and the viewers on YouTube who cannot see the chat. So the first question is that what is the biological agent or choice for scleritis? And I'm assuming it is non-infectious scleritis. So we'll start with the panelist, Dr. Biswas, then you can add your inputs.
Yes. That will be also very good expert panel.
Correct, yeah. So Dr. Basu is there since he missed out on the previous session. Okay, I'm not sure if he's connected. Yeah, Dr. Basu, can you hear us? Okay, he's not there. Then Dr. Ratinam, madam, if you're there.
I am here.
Hi.
Yeah, scleritis, when it is associated with systemic condition like vagus granulomatosis, rheumatoid arthritis, not coming under control with routine disease modifying agents, we go in for new biologicals. But as a first line therapy, I don't start new biologicals. I start with routine steroid and DMRD. When it is recalcitrant, I go for new biological. Especially most of my vagus granulomatosis cases, invariably they need new biologicals because it is a high mortality disease. So we have to hit the disease very hard. And some of my VKH and JRA and severe cases of Behçet's, new biologicals. That too after trying with steroid and disease modifying agents like methotrexate or mycophenolate mofetil. So scleritis with systemic disease, I go for new biologicals.
Okay, so you go for new biologicals once you start on immunosuppressants and the first line treatment with steroids. Okay.
Yeah.
Dr. Padma, your thoughts on this topic of non-infectious scleritis? Yes.
Non-infectious scleritis, whether it's necrotizing or non-necrotizing, is of important. If it's a necrotizing, we will be more aggressive in necrotizing scleritis. Again, we'll try to find out what is the probable etiology. It could be secondary to rheumatoid arthritis or any other autoimmune diseases. Commonly, the necrotizing scleritis is associated with the granulomatosis polyangiitis is the one we see. In that situations, if it's necrotizing, we'll go for IV methylprednisolone. Along with that, either systemic immunosuppressive therapy or biologics. It depends upon the affordability and the systemic involvement of the patient. Then, in that case, the preferred biologics is injection rituximab.
I agree with Dr. Padma Malini. I have experience with using rituximab, but non-infectious scleritis, we have used JAK inhibitor, tofacitinib. It's found to be quite useful, but not in necrotizing scleritis. Necrotizing scleritis, I prefer to use rituximab when they're recalcitrant to DMRD.
Okay. Thank you so much. Dr. Amit, I want to come to you for this question. First of all, your experience with biologics and the other question which is mentioned here. When would you consider biologics as a first line agent? Would you consider as a first line agent? If yes, in what condition? If no, when would you consider biologics for your patients?
So I tell all my patients that you have three drugs, A, B, and C. A is steroid, B is immunosuppressant, C is biologics. So you will require A and B always when you do C. You can never start C without these two. And you have to understand the onset of action. The onset of action of steroid is the most effective. If the steroid has no side effects, you could give 1 milligram per kg body weight for years. That is the most effective drug. So the B and C are not as effective as steroids. If it's side-threatening, you will require IV steroids or aggressive management. Any biological you give will require 4 to 6 weeks of effectivity. So it's not never going to be that you give biological to be effective in 1 week. Never. You will have to give steroids with it. Number two is the only case where you're going to make a huge difference is Behçet. In GIA, it's not blinding, but if you have a patient who has extreme cataract and you have glaucoma and you want to avoid steroids, then biologicals can be given in association with methotrexate. But anyway, whenever you start drugs in a patient, it takes about a week's time to give a biological because you need to investigate, get a CT test done, get all the blood tests done. So on day one, you will have to give steroid. I've been giving this for 10 years now. As per the other question, scleritis, if you were to compare TNF, JAK inhibitors, and rituximab is the most effective drug for scleritis. Across whether you do IgG4, idiopathic, SLE, you will get the best result. But the only problem is that it has the maximum side effects and the effect lasts for a year. If you have a patient of scleritis who's partly controlled, has mild disease, you may want to do ADA or you might want to use JAK inhibitors in addition because you have time. You will not lose the eye. But if you have a very aggressive disease, rituximab is the most effective drug for scleritis. I have had failures with all the other drugs where rituximab works. So now, post-COVID, I know why the scleritis has gone up. The ANCA positivity in the cases with rheumatologists, the IgG4, all gone up. And I'm giving almost one rituximab a month or maybe more. My rheumatologist is giving much more higher drugs. And so rituximab is most effective for scleritis.
I agree with Dr. Amit. After COVID, the number of episcleritis and scleritis has gone really high. It's very disturbing.
Yeah. So the
Yeah,
question
and
which
plus
was,
it doesn't go away that fast as well. The
Yeah,
upside as well.
absolutely.
It tends to be for longer period of time. Yeah.
Yeah.
Okay. So we spoke about different advantages and all. I want to digress a little bit in terms of counseling for a patient as well. And what we know that starting biologics can be double-edged sword, where there can be recurrence or activation of pulmonary tuberculosis. So any light on that in terms of how to manage the complications, how do you counsel a patient? Maybe Dr. Padma, you can take this question first.
There are biologics, like you said, it's a double-edged sword. Most what we face is expansive. The affordability and compliance of the patient has to be counseled. If they are fit enough, then only we'll go ahead with that. And the second thing, what we face commonly is um, India being a hyperendemic for TB. TB has to be ruled out before we start these patients on biologics. We have to do for TB screening, and we have to do for demyelinating diseases to be ruled out before we start the patient on biologics or any other infections. We do the liver functions, renal functions, immunodeficiency states, all this we rule out, and then we start the patient on biologics. And most importantly, they are more prone for infections because recurrent respiratory tract infections and other infections is common, that also we need to counsel the patient. What are the complications we face when we put the patient on biologics? One, autoantibody production. So for that, we usually combine biologics with DMAT like methotrexate to decrease the antibody production. So we don't have the facility to estimate the antibody levels in India. So we use the drug, DMAT drug along with that. And the second thing, chances of malignancy are also have been listed, but it is very rare with the biologics. So chances of infection, chances of malignancy are there, and reactivation of tuberculosis and opportunistic infections. These are the things is commonest with the biologic agents.
Yeah. Dr. Amit, coming back to you, do you start the biologics on your own or you refer to a rheumatologist is the first question. Second is, we know that few vaccinations are required prior to starting biologics. So what are your thoughts on that?
because I'm lucky to work in a hospital that has both pediatric and adult rheumatology. So I do a joint practice, we run a joint clinic. Second thing is all live vaccines are not given when you're on this on the biologic. You have to wait 6 weeks before you give a dead attenuated. You use attenuated or a dead vaccine to be used.
Correct.
That is important.
Okay, so Dr. Ratnam, coming back to you in terms of, so Dr. Amit does have the advantage of working in a multi-specialty hospital, but since you and Dr. Padma and like we are all working in the eye hospital itself, so how do you go about with it? You have a good relationship with the rheumatologist who takes care of this?
Yeah, I have three rheumatologists in our city. So I choose according to the time of presentation of the patient. Somebody does morning practice, somebody does evening practice. And one person is very, very conservative and one person is very aggressive. So I select accordingly.
Yeah, I think that is how it goes. Yeah, it's true. Thank you so much for that answer. Yeah. I have another question. So we have time for a question, especially say for pediatric non-infectious uveitis, because see the challenge is that if you start steroids, you can't continue for long. It's going to affect your hypothalamic pituitary axis, and somewhere the menarche in women, in girls, as well as the puberty in boys, is it affects to an extent. So, how do you tackle such kind of pediatric non-infectious uveitis, and what is the role of biologics in this? For this question, I want Dr. Biswas also to come in once the panel speaks. So, Dr. Padma, you want to go first?
Basically, like, the steroids definitely has a role in altering the cycle. Uh, so especially in pediatric cases, we are very careful. We start and try to taper off the steroids as quickly as possible. Either we maintain them with the drugs like immunosuppressives like methotrexate, or go for biologics like injection adalimumab with methotrexate. If with the biologics, I did not come across a practical uh, cycle related issues. With steroids, yes, it is common. Or in immunosuppressive agents, they do have some delayed cycles. So by and large, biologics safe. We have used it in pediatric cases. Injection adalimumab is the commonly used drug. The followed by injection infliximab. These two works well. In scleritis cases, I've used rituximab. These are the three commonly used drug in pediatric age group.
Yeah. So, Dr. Amit and Dr. Ratnam, your comments on especially pediatric non-infectious uveitis, because that is somewhere a challenge as well. How do you approach that?
Yeah, our rheumatologist prefer adalimumab over rituximab. He usually selects rituximab patients with vagus granulomatosis and scleritis. All other patients are on adalimumab. PKH, Behçet's, all pediatric agents are on adalimumab.
Okay, Dr. Amit, and then finally Dr. Biswas. Yeah.
Yeah. So you divide them into anterior and posterior uveitis. If you see DI, which is the bulk, you don't need to give oral steroid. You need to be with the steroid drops. You can start methotrexate, start on. And if you think it's high risk, you can plan to give ADA within a month. If you think it's going to take time, you can wait 3 months. If I follow two protocols, the first most aggressive protocol is from Mass General, which says that you have to be steroid-free, topical, and oral within 3 months. That a concept I've been doing now pediatric JI for 25 years, and that concept has been coming that if you are steroid-free, drops and this thing. But the American College of Uveitis and the European say you can go up to 2 drops, say at the end of 3 months. So you may not be as aggressive within, if you can leave 2 drops a time for 1 year also. If you have a mild uveitis, you may not want to give ADA, just methotrexate. But 1/3 of my patients require ADA. I've just published in the EULAR conference, we published a 10-year series, and we found that 1/3 of a patient will require adalimumab to be steroid drop.
Okay.
For posterior uveitis, yes, you will give oral steroids, and you want to be again steroid free within 3 months. You will start plan ADA early. You have to always remember that whenever you add one more drug, you have to understand it will take about a month to add. So at the end of 1 month, if my patient requires, say, more than 0.5 milligram of steroids per kg body weight, then I know this patient is not going to get control in 3 months' time. I need to initiate ADA early. You start now. What you have to understand, ADA, all biologicals are better tolerated for the first 1 year than your IMTs. Azathioprine, methotrexate will give more side effects, intolerance, not side effect, intolerance, say vomiting, nausea in a child, then giving biologicals. If you were to give biologicals, the biological side effects like psoriasis, skin lesions generally come after 1 year, except for the TB and say herpes, which is much more active now with JAK inhibitors. I have found that the tolerance to ADA is better than your methotrexate because 90% of patients complain of vomiting and nausea, or sometimes they get nausea even at the thought of injection. So if you see Dr. Ramanan's paper, he says in the era of biologicals, 1/3 of your pediatric patients will require biologicals.
Okay, thank you.
I agree with him.
Yeah. Maybe before I bring in Dr. Biswas, I just want to try one more time. Dr. Basu, are you there?
I echo with Dr. Amit. I have almost switched over to biologic agents in the JIA patients, and except in the very acute stage when they require a short course of oral steroid, but later on they have switched over to adalimumab if they can afford. And none of my patients are on chronic oral steroids or chronic topical steroids, and they are on biologic agents and non-steroidal anti-inflammatory agents. With the biologic agents, you can control the inflammation and switch. Even the use of topical steroids is reduced quite significantly.
The other thing I've tried is that those patients who couldn't control, were not able to afford ADA, we started the JAK inhibitors. You were even part of the systemic onset trial but we found that JAK inhibitors are not as effective as
Yes.
TNF in any form of uveitis because they attack at multiple levels of, they don't target one uh, chemical like TNF. They affect 3 or 4 levels intracellularly. So they have a diffuse effect and they don't are not as effective as the normal biologics. Yes, it is a because they were used commonly in COVID time. We started using them, but they are not as effective, and we don't have a randomized clinical trial at the moment to say that they're anyway superior to TNF block. But my experience is TNF is superior to JAK.
I also agree with you. I also agree with you. I have started using JAK inhibitors, but I'm not that very ecstatic about JAK inhibitors in uveitis. But they are working very good in scleritis patients. And adalimumab is my first choice of biologic agents in Behçet's, GIA, and BKH recalcitrant cases.
Okay. Maybe one last question. It's a very naive question. So along with the biologics, the immunosuppressants also go on, right?
Yes.
When
Yes.
do you consider stopping the immunosuppressive agents, or do you stop the biologics first and the immunosuppressants go on?
No, immunosuppressive first.
Okay.
So the thing why you're giving the immunosuppressive is to prevent the antibody formation.
Yeah.
Yeah.
So at the end of 1 or 2 years, you find in certain group of patients that some patients become less effective and they have a recurrence of UVI. Not that they reduce the dose. So there are 2 ways of doing that: is increasing your methotrexate when you have a recurrence, or you can shift to other drugs like golimumab or infliximab and then come back to ADA later. So we have few patients who became ineffective on ADA and we shifted them to golimumab because they develop antibodies. So we don't have antibody form checking in India, but the gold standard worldwide is either you go to weekly dose, you increase the dose, or you shift to the other and come back. The other thing is that in adalimumab, you have standard injection 20 milligram and 40 milligram. You cannot change the dose as per the weight. If a person is not getting control with ADA at 40 and it is 120 kg, then you may want to go to infliximab because infliximab you can change the dose according to the weight. But you are 20 and 40 milligrams. So sometimes in a child, the standard is a child less than 30 kg, you do 20 milligram, and above 30 kg, you go to 40 milligram. So sometimes when we find a patient is 30, we don't go to 40 immediately. We do 20 1 week and 40 next week, the next injection. So an average of 30. So in ADA, there's a fixed dose regimen. So you sometimes may have patients who are not as effective. You may need to shift to the other. Even golimumab is a fixed dose. Only infliximab is variable according to the weight. And yes, you can get an insurance cover also within.
Okay. Thank you so
Can I
much for this
just
wonderful insight. Yes, yeah, please.
Yeah, one thing we all discussed about which drug do you choose and what, and just from for the benefit of the postgraduates, indication of biologics in uveitis if the patient has JIA associated uveitis or ankylosing spondylitis, occlusive vasculitis secondary to Behçet's disease, or necrotizing scleritis secondary to GPA. These are the common indications where we start biologics.
Thank you, Dr. Padma. So that was an extensive discussion on biologics, one of the good sessions here. We move on next to one of the, I feel, most relevant talk in terms of for the postgraduate ophthalmologists. And I can think of no other better person than Dr. Partha Pratim Datta Majumdar for this talk. The talk is titled Clinically Relevant Retinal Anatomy Postgraduates Must Know. And to speak about Dr. Majumdar, he is an avid photographer, apart from an ophthalmologist, a wonderful athlete. And he completed his fellowship from Shankar Netralaya and he joined there and is working there. And he's being awarded multiple awards, notably the TLK Rao Endowment Award, Natarajan Pillai Award, K. Datta Award. And he's editor of Insight, Scientific Journal of Medical and Vision Research Foundation, section editor of IGO. So he has written more than 50 chapters in various books, published extensively. He has 2 CME series booklets on PCR in ophthalmology and scleral inflammations. And more importantly, from the PG's point of view, we all know how popular eOphtha is. He is the founder, chief editor of eOphtha. So over to you, Dr. Datta, for your talk. Most awaited.
Thanks, thanks, Babik. Hope I'm audible and you can see my slides.
You are audible, but it's a white screen. If you can go to the next slide.
Yeah, I'll go. Just I want to minimize this.
Okay, we can see your screen now.
Yeah. So,
oh yes, please.
Yeah. So, good evening, esteemed panelists. Thanks, Vavik, for your nice and kind introduction. And also good evening to the postgraduates, especially who are watching or will be watching this unique initiative by AIOS called GuruSangam. So today I'll be discussing some important anatomical aspects of the retina. And this talk designed specifically for the postgraduate students. The diagrams and the illustration I have used were drawn by me to simplify the complex concepts of the retinal anatomy. I hope you people, the postgraduates, will find it helpful. If anyone has any questions, please feel free to ask during the session, or you can email me if you are watching it later in YouTube. So due to the limited time, I won't be able to cover the entire retinal anatomy in detail. I'll be begin by highlighting the key landmarks of the fundus, followed by touching the epithelial lining of the retina and the surrounding structures, blood supply to the retina and surrounding structures, and also I'll discuss about the layers of the retina, and lastly I'll touch the blood-ocular barrier. So to start with the landmark in retina, let's first start with that ora serrata. As we know that ora serrata is the scalloped anterior margin of the sensory retina. And this is a transition zone where the neuroretina is continuous with the columnar non-pigmented epithelial cells of the pars plana. We'll see how the cellular linings are there. And you have to understand that the two unique structures can be seen in ora serrata. So the one is that rounded extension. You can see here in green color of the pars plana at the ora serrata. These are called ora base. And you can see the teeth-like extensions of the retina between the ora base, which are known as dentate processes. Now, ora serrata is situated 6 millimeter from the nasal limbus, whereas the temporal limbus, this distance is 7 millimeter. Now, if you see here, it is 5 millimeter in front of the equator. And the ora serrata just lies beneath the spiral of Tillaks. Now, what is spiral of Tillaks? It is a spiral that describes the insertion points of the 4 extraocular rectus muscles in the eye. Now, you have to understand that this is a very important anatomy which we are discussing. You can see here the ora serrata. You can also see the approximate location of the equator, and you can see the posterior pole, and in between there is a mid periphery, and sometimes we call that part beyond that is far periphery. Now this is very important. What is this name of this chart? The name of the chart is Amsler-Dubois chart. So now let me just give an example for what areas do these circles represent. For example, if you see a lattice between the ora serrata and the equator, should be drawn in which? Anyone can guess? So I'll give you the answer since we are watching, we are in a virtual mode. So what we see here, you have to understand that these are the part, the ora serrata is represented by here the blue circle. And you see here the equator is drawn in red color. So the red circle represents the equator. So you should not confuse between this. You have to understand that the last circle is not the ora serrata. Ora serrata is the middle one. And if you are if you are drawing a this thing, then the lattice will be anterior to the ora serrata and junction of the pars plana and pars plicatum. So I think hope you have understood how this chart represents the various anatomical landmark here. So now coming to the epithelial lining of the retina and surrounding structure, I'll start the discussion with the iris epithelial lining. Now, iris and ciliary body, they have a double layer epithelium. The anterior pigment epithelium of the iris continues as a outer pigment epithelium of the ciliary body facing the ciliary body stroma, and finally transitions in the retinal epithelium. And the posterior epithelium, pigment epithelium of the iris is represented here. And you have to understand that the anterior iris has no epithelium and the posterior iris is lined with a double layer of the cuboidal epithelium. Now, if you see here, the anterior pigment epithelium of the iris is continuing as a posterior pigment epithelium of ciliary body. You can see here the facing the ciliary body stroma, and finally transitions into the retinal pigment epithelium as it continues posteriorly. Correct. So now you have to understand also in anatomical context, in retinal anatomy specifically, what does the word outer intend to convey. So in ocular anatomy, the outer means closer to the eye wall, and the term inner means that it is closer to the center of the globe, pointing towards the globe. Now, you have to also understand the basic alignment of this, that the basal membrane of the non-pigmented epithelium of the ciliary body, which continues with the internal limiting membrane of the retina. So, now, here you have to understand a very interesting anatomical aspect, that the iris is continuing with ciliary body and retina. Now, what is common in between them? They have a dual layer of epithelium, and both these layers are having apex to apex configuration, right? Now, this actually represents that the anterior pigment epithelium and posterior pigment epithelium of the iris, and outer pigment epithelium and inner non-pigmented epithelium of the ciliary body, and outer segment photoreceptors and the retinal pigment epithelium. So these are all arranged in a apex to apex configuration, and this comes from the embryological origin. Now, when we are talking about epithelium, I'll touch the retinal pigment epithelium here also. So here you have to understand that the attachment between the RP and neuron retina is very weak, and we have RP pump, which actually plays a very important role. Now, RP is basically a single layer of cells and rests on a basement membrane that forms the Brooks membrane of the choroid. Now, the RP pump refers to the active transport mechanism performed by the retinal pigment epithelium, and it plays a crucial role in maintaining the ionic and fluid balance of the retina. Now, RP pump utilizes the energy generated by the sodium-potassium ATPase pump, which are embedded in the plasma membrane of the RP cells, and this pump actively transports these sodium ions out of the RP cells in exchange with 2 potassium ion, which is brought into the cells. Now, this movement creates an osmotic gradient leading to a movement of the water across the RP layer, and water follows the concentration gradients established by this ionic transport. So this results into absorption of the fluid from the subretinal space, and its subsequent release into the choroid. So disruption or the dysfunction of the RP pump can lead to retinal diseases like, as you know, which happens in exudative retinal detachment. Now, function of the RP, the postgraduates, you people can remember it as a fit RP or RP fit. So you can see here that the RP attachment is the first cause, and then it can cause retinoid metabolism. It also helps in retinal renewal of the photoreceptors, photoreceptor matrix, protection of the blood retinal barrier, elimination of the waste, free radical scavenging, immunoregulation, and transport of water and metabolites. So quickly, I'll go into the one of the critical function of the RP. So one of the critical function is that the RP serve is a phagocytosis of the photoreceptors outer segment. This is the disc. So now what happens here? Photoreceptors, these are continuously shed daily, and it is phagocytes by the RP. Now what happens here? You will see here that within the RP, these phagocytous outer segments are metabolized and digested by the lysosome. Now, when it is digested by the lysosome, the end products are reused to synthesize the new disc, except for the material that cannot be digested. So, the undigested products in RPE causes a buildup of lysosomal residual bodies, which is called lipofuscin. And sometimes in disease condition of the eye, there is more accumulation of this pigment. So now what happens here? This comes as to a unique characteristic of these molecules are called fluorophores. Now this autofluorescence of the retina is due to the presence of that several fluorophores which emit the light when excited by a specific light source. So these fluorophores are mainly located into the RP and outer segment of the cells and can play a very important role in fundus autofluorescence. Now I'll just now go into the blood supply of the retina and surrounding structure. So quickly, all of you know that the internal carotid artery gives rise to the ophthalmic artery. One practical point here, that if you see the various textbook, or you read the details about the endogenous ophthalmitis, it is said that the right eye is more commonly involved, probably due to the more direct route through the right carotid artery. Now, what happens here? You can see here the right common carotid artery has a shorter and more direct course than the right internal carotid artery. So this causes that this phenomenon. So now the branches of the ophthalmic artery, sometimes it is asked as a important question in the theory exam, and you have to understand, you can use this as a mnemonic, though these are not used in a sequential list. So these are the list, so you can use it as a Dr. Maculus for remembering the name of these branches. So coming to the applied anatomy of this, the ocular hypoperfusion due to the stenosis and occlusion of the common or internal carotid artery can lead to the ocular ischemic syndrome, and fundus fluorescence angiography, this is reflected by prolonged retinal arteriovenous passage time and prolonged choroidal filling time. Now, coming to here, you have to understand that the cherry red spot. So what happens while the central retinal artery supplies the inner 2/3 of the retina, the outer third, including the macula, receives the blood supply from the choroid, which is supplied by, you can see here in the diagram, supplied by the short and long posterior ciliary arteries. So what happens when we deal with the central retinal artery occlusion? The surrounding retina becomes totally pale due to the retinal artery infarction, while the macula, which receives the blood supply from the choroid, which comes from the short posterior ciliary artery, and so they remain perfused, creating a cherry red appearance. Now, however, you have to understand that when there is an ophthalmic artery occlusion, the no cherry red spot can be seen because choroid is also affected. However, the cherry red spot-like appearance can be seen in these conditions due to the nerve fiber layer, which becomes edematous due to ischemia in the later course of the disease. So now coming here, the retinal artery, you have to understand the ciliary retinal artery is a small blood vessels that arise from the ciliary circulation and supplies the blood to a portion of the retina, often including the macula. So now this ciliary retinal artery can be approximately seen in 15 to 30% of the population, and the presence of a cilioretinal artery can provide a protective effect during a CRO, and as this helps to maintain the blood supply to the macula and preserve the central retinal vision. Now, a very interesting question is, what is amyloidic sign? So those who don't know this, you have to know the basic, that amyloidic triangular sign is a rare phenomenon which indicates the choroidal ischemia. So this is characterized by a triangular pigmentary disturbances in the fundus, typically pointing towards the posterior pole or the optic disc, and it is caused by the occlusion of the posterior ciliary artery and other large choroidal vessels associated with CRO and BRO. Most commonly, these are associated with either CRO or BRO. But this indicates possible systemic vascular risk. So this patient should be investigated for systemic diseases. Now I'll touch a little bit of choroidal blood vessels here. So if you see here, the choroidal vessels has a lobulated pattern of vasculature, which is divided into capillaries, then the medium-sized vessels and the large vessels, and all this collect the blood from the posterior ciliary arteries. Now, if you see here, you will see here the capillaries are the wide bore fenestrated capillaries, and the satellar layer has a medium-sized vessel, and the halar layers has a large veins that lead to the vortex vein, and they have no valves. Now, if you see here, you will see that the large or wide bore of the fenestrated choriocapillaries are responsible for choroidal flush after the fluorescein injection. And also you need to understand that the major choroidal vessels are impermeable to the choroidal fluorescein. But the choriocapillaries, they can leak the fluorescein dye into the extravasated space. So that's why we see this phenomenon. And coming to the another important point is that pachychoroid. There will be several discussions there. Just to give you the anatomical perspective of that, it's a state of focal or diffuse increase in the choroidal thickness. And if you can see here that this structure, just now I showed you, and you see here, so if there is a thickened halar layers, so there will be compression and attenuation of the satellar layer and the choriocapillaries, and the RPA dysfunctions and the pigmentary changes can be seen. So now coming to that, you can see here that again I have a diagram showing that the halars layer and satellites layer and how these are compressing the stem. Now this is a very important part of the applied anatomy, that from choriocapillaries the blood is collected into the venules, and this coalesces and collecting channels or ampulla of the vortex vein. Now remember here, next slide I'll show you the ampulla of the vortex vein. But this vortex vein ampullae, they exit the eye as a vortex veins and drain into the superior and inferior ophthalmic veins. Now you see here, these are a picture I have taken in a melanotic fundus. So you can see here that the slightly raised and the dark red or purplish spots in the fundus, which is typically seen in 1, 5, 7 or 11 o'clock position, and these are the vortex vein ampullae. So now what happens here? The vortex veins drains the excess fluid from the choroid, right? Now this vortex vein acts as a sink for the excess fluid, drawing it away from the choroid. So this plays a huge role because the pressure in the vortex veins is lower than the choroid. So that drives the fluid always towards the vortex vein from the choroid. Now, there are valves which prevent the retrograde flow of the blood from vortex vein to the choroid. So the blood flows only in direction towards the sclera and away from the choroid. Now, if there is a mechanism, there is a disturbance in this mechanism, then we see the choroidal detachment, which occurs when the fluid accumulates between the choroid and the sclera, causing the separation of the two layers. And interestingly, this choroidal detachment is typically quadrilobular because of this vortex vein. I told you that the position of the vortex vein. No, so this attachment of the vortex veins also limit the spread of the detachment anteriorly. So that's why you see the choroidal detachment in such configuration. So now coming to the layers retina, Vavik, I'll just finish in time. So this is a very quiz time. I always ask the postgraduates, even though it is thin and its mechanical strength is in megapascal range, which is same as articular cartilage and about 1,000 times stronger than any cell layers in our human body. And it contributes to at least 50% of the rigidity of the retina. Can you tell me which structure I am talking about? It is the internal limiting membrane. It is such a tough membrane. The retinal surgeon, they don't realize when they peel this membrane, but this is how the stiff this membrane is. So now coming to this, I won't go into the details of this. This is a very important diagram and it's a very important article. I request all the postgraduates to read this article for better understanding of the retinal layer in the OCT. But I'll just go here in this, how the configurations are arranged in retina. We have broadly 3 categories of cells. We have neurons, glial cells, and vasculars. So neurons, again, we have photoreceptors, the bipolar cells, the ganglion cells, amacrine cells, and horizontal cells. Now, all the neurons can be actually belonging to this pathway. One is vertical pathway and the horizontal pathway. In horizontal pathway, we have the amacrine cells, which interconnects the bipolar cells and the ganglion cells you can see here in this diagram. And the horizontal cells, which interconnects that photoreceptors. And the vertical pathway, which goes from photoreceptor to bipolar cells, ganglion cells, and to the axis. So now the glial cells are mainly the collections of the Muller cells. The foot process of the Muller cells also forms the internal limiting membrane of the retina. Now, the glial cells are also like astrocytes and the microglia. Let's see quickly the diagrams here. So I won't go into the details of this structural thing. They are responsible for the hemostasis of metabolic support of retina, structural support and integrity. Muller cells can become highly reactive during the retinal detachment, playing a crucial role in repair. And they also play an important role into the retinal injury and diseases. And we can see this microglia and astrocytes, and they actually starts proliferating, and a process called gliosis. So whatever gliosis we see here is in response to the injury is by these cells. Now, if you ask me specifically that what are the functions of each three individual cells, I have summarized it in such a way. The microglia, you can just remember them as a macrophage of the retina. The Muller cells, you can just remember them as a primary support cells of the retina, which helps in repair. And the astrocytes are the vascular regulators of the retina. Now, coming to this important, all of you know about the mactals. So, as you know that as the Muller cell processes lie deep to the deep capillary plexuses, which will be showing in the next slides. So, there will be the telangiectasia in the deep capillary plexus, and there will be progressive collapse of the retinal layers, and it can actually lead to that appearance of the right-angled vessels. So, I'll go into the vascular layers. This is all endothelial cells and pericytes. All of you know. I won't spend much time here. So pericytes, you know that the ratio of the pericytes to vascular endothelial cells in retina is also greater than in the other vascular bed, and the ratio of pericytes and endothelial cell is 1:1. And the pericyte loss is a hallmark of the diabetic retinopathy. Now, you have to, if you see the configuration of this retina here, you will see that between internal limiting membrane and the external limiting membrane, retina consists of alternating layers of cell process and cell bodies. There is a layer of cell process in the nerve fiber layer, and again the subsequent next layer, the ganglion cell, we have cell bodies. Again, the inner plexiform layer, we have a cell process, and then next layer is cell bodies. So these are basically the alternating layers of cell process and the cell bodies, which is arranged it this way. Now, if you see here, the nerve fiber layer consists of axons of the ganglion cells. The ganglion cell layer consists of the cell bodies of the ganglion cells. The inner plexiform layer consists of the axons of the bipolar cells and the dendrites of the ganglion cells. And the inner nuclear layer is consists of cell bodies of the bipolar and the amacrine and horizontal cells. The next layer is outer plexiform layer, which composed of axons of the photoreceptors and dendrites of the bipolar cells. Now, if you see the next layer, the outer nuclear layer, it is again the cell bodies of the photoreceptors, and subsequent next layer is your external limiting membrane. Now, I'll just touch few pathologies like the cottonwool spots, hard exudates, flame-shaped hemorrhage, and blot hemorrhages. Now, if you see here, the cottonwool spots, it affects the nerve fiber layer of the axons of the ganglion cells. It suspects, it usually indicates that ischemic microvascular disease and results due to the interrupted exoplasmic transport between the retinal ganglion cells and its synapse in the lateral geniculate body. So that's where, here is that red mark you can see here, the cottonwool spots can be seen. Now, the next pathology is that hard exudates. So, hard exudates can be is formed by a deposition of the lipid and lipoproteins, and these are the signs of abnormal vascular permeability from either optic disc, retina, or subretinal vessels. So, within the retina, the hard exudates are seen as a yellowish, you know, here in this picture. So, the outer plexiform layer, as indicated by a red layer, you can see here. This is the location of that hard exudates. Now, where the blood vessels are located in retina, let me show you in a diagram. You can see here the more clearly here, you can see here the retinal vessels are located in nerve fiber layers. They are also the superficial network is seen in the nerve fiber layer or in ganglion cell layer, and the deeper network is situated in the inner nuclear layer or near the outer plexiform layer. Now, the flame-shaped hemorrhage, the flame-shaped hemorrhages are seen in the nerve fiber layer, and when the blood is released into the nerve fiber layer, it tends to spread along the direction of the nerve fibers, creating a flame-shaped appearance. Now, compared to that flame-shaped hemorrhages, the blot hemorrhages lie deeper in the retina. You can see in red layer, the deeper in the retina, in the plexiform, in the inner nuclear layer, and seen in a peripheral retina where the nerve fibers are thin. And in this reason, the vertical arrangement of the Muller cells and the neurons limit the lateral spread. That's why it is blot shaped. So now coming to the new vascular formation, you can see, all of you know that the superficial and intraretinal vascular plexus provide the oxygen and nutrient to the inner 2/3 of the retina, whereas the outer 1/3 of the retina, the photoreceptors and the retinal pigment epithelium or RPE, receives the blood supply from the choroidal circulation. Now, the two new vessels in the retina occurs due to pre-retinal angiogenesis or subretinal or choroidal neogenesis. So now all of you know that pre-retinal angiogenesis occurs in here, in this area. So it involves the proliferation, and these are fragile and bleeds easily. Whereas the subretinal neovascularization occurs in the choroidal circulation and grow through the breaks in the Brooks membrane under the RPs, sensory neural retina, and combination of both. But there are certain conditions where in some cases the neovascularization forms in the neurosensory retina and in later forms the anastomosis with the choroidal circulation, which is also known as retinal angiomatosis proliferans or VAP. So coming to my last topic, the blood-ocular barrier. So blood-ocular barrier, all of you know, it helps in protection, homeostasis, and the immune regulation. And the blood aqueous barrier is the first one, which prevents the aqueous mixing with the serum and plays a pivotal role in the aqueous composition and making it clear and to help the eye see clearly. So to maintain this optical clarity is the primary this thing. And it consists of the capillary endothelial cells of the tight junction between the capillary endothelial cells of the iris and also non-pigmented ciliary epithelial cells, which form the tight junction to prevent the solute movements. Coming to the blood-retinal barrier, the blood-retinal barrier regulates the fluids and molecular movement between the ocular vascular beds and the retinal tissues. The blood-retinal barrier allows the neural retina to maintain and establish an environment for the neurosensory and proper function of the retina, and it also consists of inner and outer component. So the inner component consists of the Muller cells, tight junction between the capillary endothelial cell and which is supported by the pericytes. Now the outer blood-retinal barrier is composed of the tight junction between the retinal pigment epithelial cells. Now this blood-retinal barrier, the failure of these tight junctions can result into the increase in the paracellular permeability, allowing the passage of the proteins and fluid into the retina and the subsequent formation of the extracellular edema. So that's how you see the damaged retinal vessels, which the retinal fluid accumulates in the retina along with the lipoproteins, which we perceive as a yellowish material. So now, can you name a gold standard test in your clinic to the integrity of this retinal vasculature? It is, yes, none other than the fundus fluorescent angiography, and it's quite similar to that we see in the checking for a leak in the cycle tower under water. So the same principle we use here, which reveals the defect by detecting the escaping fluid instead of the air. Thank you.
I think no other person can give this talk as the way you gave it. Thank you so much, Dr. Majumdar.
I also agree with you. Fantastic talk. Fantastic.
And especially when we go to the basics, it becomes even more tougher. So yeah. I understand the question of the session maybe also in that sense. So I want to start with very basic questions for our PGs in terms of if the panel can enumerate what are the anatomical changes which happen in a case of acute anterior-uveitis and the chronic anterior-uveitis. I think that is the question to start off with whenever Viva starts for the PGs as well. So I want you to highlight the important clinical findings which they have to understand and not miss out. So first we'll start with Dr. Rathinam in terms of acute anterior-uveitis.
In acute anterior-uveitis, we can take HLA-B27 as the example.
Okay.
And it is always has tendency for posterior synechiae because of the fibrin content is more there. So the hypopyon will be turbid in color and it will be floating also. It is not fluid level hypopyon. And always tendency for posterior synechiae, even it goes for 360-degree synechiae and very aggressive. It is acute usually recurrent and alternating unilateral anterior uveitis, non-granulomatous anterior uveitis. And the most important thing is to dilate the pupil in order to avoid synechiae. And early eye drops is extremely important. And if by chance, if you are not able to break the synechiae, the patient may go in for angle closure glaucoma. So, iris bulb and angle closure glaucoma. So, some authorities prefer to give midricaine injection in order to avoid ring synechiae. And in contrast, chronic anterior uveitis will not have that very severe red blood eye. It's quiet and it is indolent. Even most of the granulomatous entities are chronic. Most of the non-granulomatous entities are acute. So there may be in sarcoid anterior uveitis, there may be some granulomatous cavities, but eye may not be red. And silently it will be going for synechiae. We will have more time to handle the synechiae in chronic anterior uveitis than in acute anterior uveitis.
Okay, thank you, Dr. Ratnam. Dr. Amit, if you're there, if not, Dr. Padma. Yeah. So my question to you is that about the blood aqueous barrier, how important is a role to ensure that the blood aqueous barrier stability is maintained, or how fast we achieve the stability of that?
So basically, you measure it by these aqueous flare and the cells.
Correct.
So classic teaching is that we have to be cells free as early as possible. But even a chronic flare will cause long-term glaucoma, will cause peripheral anterior synechiae or synechiae. The risk of glaucoma and cataract go up higher when you have a high flare also. So now that we are more aggressive with our treatments, we need to tell the residents that only topical steroid is not the treatment for choice for clear uveitis. You require systemic, you require immunosuppression. So as we use more and more early immunosuppression in uveitis, in pediatric and adult who have more than 2 or 3 attacks, and to reduce the amount of flare in cells and just reduce the long-term complications of peripheral anterior synechiae and glaucoma.
Okay. So thank you so much, Dr. Amit. The next question I'd like to bring in Dr. Partho and Dr. Padma both. One of the chronic sequelae and the dreaded complication of uveitis is hypotony, which we do not want the patient to have that complication. It's difficult to manage. So my question here is, why does the hypotony happen in the first place? What are the anatomical changes which happen, which lead to hypotony?
In severe uveitis, especially in acute uveitis, sometimes they can have a ciliary body shutdown that is responsible for the low pressure in the eye, or can have anatomical changes in the eye like ciliary body detachment or retinal detachment. These are the things that are responsible for the low tension in the eye, which can be brought out if severe control of inflammation is obtained with the use of steroid therapy, and we can bring down the pressure. The next question comes in chronic uveitis, you can have hypertony. That is the most warning sign. So whenever we see a child, especially it's seen in JE associated uveitis, when there is a chronic, when there is not adequate immunosuppressive therapy or it's not appropriately managed, they land up with structural changes like band-shaped keratopathy, posterior synechiae, complicated cataract with hypotony. In that situation, when the media is not very clear, we can do ultrasound biomicroscopy, which help us to assess the ciliary body status. Sometimes if the permanent damages occurred in the ciliary body status, then the hypotony is going to be permanent. You assess the ciliary body status. Based on that, we can make out it's secondary to uveitic and inflammation or due to the structural changes. If it's due to uveitic, we can bring it down, control with the medications and anti-inflammatory therapy. If there is a structural change, we may have to subject the child for surgery, and we may not be able to restore the intraocular pressure in such cases. In that way, we have to do the surgical modifications and silicone oil injection and things to be done, but we can prognosticate. It's very, very, very important whenever you're taking up a uveitic cataract for surgery, especially if the patient has hypotony, we need to assess the ciliary body status to give the prognosis after the surgery.
Yes, Dr. Partho. Yeah.
Yeah, no, Bhavik, I think Padma ma'am has already answered your question. Can I go back to your first question, because that
Sure, yes,
So,
absolutely.
and you have to give me 3 minutes for that.
We have a lot of time, no problem. Yes.
So what happens in uveitis basically, be it acute, mainly I'll start with acute. So there will be breach in the blood aqueous barrier. So whenever there is a blood aqueous barrier, so the fluids will start coming into the iris tissues from the blood vessels, and similarly the various inflammatory cells also will come out. So what will happen there? So the iris, because of this extravasated fluid, it will become like boggy kind of structure. So that's why in uveitis we see the sluggish movement of the iris, and sometimes classically it is called as a muddy iris, because iris is swollen because of the extravasated fluid. Now, when iris is now full of that, there will be a lot of inflammatory chemicals will come, the like cytokines and all, and this will start acting on the iris muscles. So there will be again this contraction of the sphincter and the dilator muscles, but the sphincter overcomes the dilator, so there will be constriction in the pupil. Now, while this is happening, then another side, from the iris, the extravasated fluid is coming into the aqueous, and this fluid is making the aqueous turbid. Now, the corneal endothelium, which is actually taking the entire nutrient from the aqueous, this is now full of the dirty materials from the which are product of inflammation. So because of that, the endothelium will start desquamating in places. Now, the inflammatory cells which has come out of the iris into the anterior chamber, they are coming into the two temperature gradient. One temperature is that warm iris, and another temperature gradient is the cold cornea. So there will be a turbulent flow of these cells, and we will see the circular movement where the inflammatory cells will be rotating. Now, the inflammatory cells are very high in number, then due to the gravitational force, they will settle into the bottom of the anterior chamber, and we perceive it as a hypopyon. And because already the aqueous, the corneal endothelium is desquamated, so these rotating cells sometimes will come and will stick to the endothelium, and which are we call them as a keratic precipitates. I think that summarizes the anterior uveitis in applied aspect.
Absolutely, yes. Thank you for that understanding. So on similar lines, if I can ask the question on vitritis, like what are the vitreous changes that lead to opacification of the vitreous? And we say that once it is treated, okay, once the vitreous comes back to normalcy. So what is that which leads the vitreous to change its opacity?
Very, very interesting question. So vitritis in classical pars plana, what we see that the breach in the blood vessels, which will be from ciliary body and the other places where the inflammation is happening, from there continuously the cellular materials are coming into the vitreous and making it inflamed. Vitreous, as of if you see, it's an inert structure. So second line of vitritis we see is because of the end product, like conditions like toxoplasmosis and acute retinal necrosis. What we are seeing is the sloughing of the retinal material which are coming into the vitreous. The virus, the parasites are destroying the retinal tissue, and combined with that, the inflammations, we are seeing a combination of that. So two things are little different, but that's how it is.
Yeah. So I want to move down more posteriorly now, in terms of, we know certain slow growing organisms, okay, like tuberculosis or even toxoplasma to an extent, they can affect or involve only certain parts like the outer retina, inner retina. Okay, so what is it that drives such organisms to be localized only to one part of the eye or one structure? See, be it only choroids. Okay, somewhere it is layer only in the choriocapillary, sometimes it is on the hallus or settlers layer, or sometimes just the outer retina or the RP. The infection is just in the RP, for example.
Yeah, this is very interesting question again. We have to see the particular pattern of this. If you see that the acute retinal necrosis, it is transmitted by the nerves, mainly the neuronal root, and it starts from the periphery because there where the termination of these ganglions are there. So from there, the virus will start migrating. So it's peripheral. Like cytomegalovirus. Cytomegalovirus, you see, it spreads by a hematogenous route. And it is extremely slow growing virus, herpetic virus, we know. So they replicates every 18 days. So compared to VZV and HSV, you compare the CMV, the VZV and VZV and HSV is much more aggressive, whereas the CMV is much slow growing organism. So second again, if you see that tuberculosis, I think Dr. Basu is there. So that again, we see that perivascular, that chorioretinal atrophies. This replicates. This actually indicates that hematogenous dysmetry of the Mycobacterium tuberculosis. Now, coming to another important point, we have the name called retinochoroiditis and chorioretinitis. So if you see that syphilis, it transmits through the choroidal vessels. So it first involved the choroid, mainly the vascular pattern. So it first involved the choroid, and then slowly it involves the retina. So we are talking about the common presentation. So we call it chorioretinitis. Also the toxoplasma. Toxoplasma, if you see, the cyst of the toxoplasma lies in the surface, the retinal surface. And from retina, it goes down to the sclera. So that's why we prefer the term that retinochoroiditis. So that's where the location of the various organisms and the mode of their transmission actually plays a role in the clinical phenotype of the these organisms.
Yeah, excellent. Thank you so much. Dr. Amit, Dr. Padma, any more points you want to add pertaining to anatomy which you feel is relevant for the PGs? Dr. Amit first. Yeah.
Dr. Partha is the expert. He's given a very detailed explanation.
Yeah. Dr. Padma, Dr. Ratinam.
Dr. Partho's an excellent talk, is very well covered and beautifully understanding of the lesions. And only one thing I would like to ask from the Bible point of view, they will ask the macula as a dual blood supply. So either it's supplied by the middle cerebral and the posterior cerebral artery. So anyone, if it gets affected, the vision is still spared. So that they need to know the answer.
Okay. Yes.
Yeah, fantastic talk on basic anatomy. And this applied anatomy is also important because sometimes the choroidal ischemia can be mistaken for other conditions, which is very common in pregnant ladies with preeclampsia. Choroidal ischemia will be the commonest presentation, which we miss. So some of the anatomical, applied anatomical points are very important for us to derive the DD. That is very well done by Partho. Thank you, Partho.
Thank you. Thank you so much. Yes. So, having understood the anatomy of the eye pertaining to UVEA, our topic here, let's dive deeper into anatomy of the retina. Okay. Our next speaker here is a very good friend of mine, and she is a fantastic retina surgeon, and she offers her services at Joshi Eye Institute in Hubli, and she also has several publications to her name, awards as well, a young achiever. She also led the Yossi academic in charge for 2 years, and several awards which she has received. With the latest one, best surgical video, the URETNA in Amsterdam 2023. So her topic is interpretation of OCT. So let's dive deeper into the OCT and dissect. And I'm sure she's going to present, make this talk very interesting. Over to you, Dr. Apurva.
Thank you. Thank you so much, Bhavik, for that kind introduction. And I'm really honored to be presenting alongside such luminaries in the field. I hope you can see my screen.
Yes, and you're audible. Please go ahead.
Okay. So my topic is interpretation of optical coherence tomography, OCT. What is it? It is a non-invasive imaging technique of the macula. OCT provides a detailed cross-sectional image of retina and choroid, and you can see how on this 3D scan, you can see all the way from the ILM to the choroid. This presentation is not about OCT for glaucoma. So what is the principle? A low coherence light source is used and a near infrared light beam is directed at the tissue. One arm is also sent to a reference mirror. The time, delay, and the magnitude of whatever light is reflected from the tissue, it is very scattered. So it is compared to the reference mirror, and the depth profile is used to create a cross-sectional image. This is an interferogram that is received, and that is analyzed to create a cross-sectional image of the macula. So that was time domain. Now we have Fourier transformations where you have spectral domain and swept source OCT. A spectrometer is different in that the detector splits the light into its composite wavelengths, and a swept source OCT uses a sweeping light source. So both of them create an A scan based on the interferogram. Spectral domain provides a high resolution with 870 nanometers and 70 to 80,000 scans per second. And the swept source has increased depth with 1080 nanometers wavelength, and 1 lakh to 4 lakh scans per second can be obtained. Enhanced depth imaging is possible in both SDOCT and subsource OCT, where a longer wavelength is used to see the choroid. If you see very carefully, you can see all the way up to the choroidoscleral junction. So how do we acquire a scan? This is the OCT console. This is a spectralis machine with no financial interests, of course. So the patient is made to sit comfortably with the headband, head resting, forehead resting on the headband and the chin rest. An external light source can be used for fixation. There you can see that the patient is fixating. Alternatively, an internal light source can be used for fixation, where you can get a very good, well-fixated OCT scan. And the scan is in the sweet spot in the reference panel. So we have to look at the scan quality. This is an example. This bar is basically telling us about the scan quality. As you progress in this bar, it reaches the end is the highest quality scan, and it is measured as sensitivity index. A radial scan. This is how a radial scan looks, where the line scans are oriented radial to the center of the fovea, whereas a raster scan has horizontal line scans which are placed at specific distances between each other, and a very dense one is also called a cube scan. So what do these arrows indicate? You can see these arrows. The arrowhead indicates the right hand portion of the OCT. So here the arrowhead shows that this is the right hand portion, and this is the inferonasal part of the macula. Here the superior arrowhead shows that the right hand portion is the superior macula. How to identify the eye? We have to look at the nerve fiber layer. The arrowhead is this side. So this is the right hand portion of the macula, and as expected, the nerve fiber layer is thick because it is the papillomacular bundle. Hence, this is the right eye. So there are different scan angles like 30-degree scan angle, 55-degree scan angle, and the width of the line scan is customizable. It can be 6 mm, 8 mm versus 12 mm like this scan, where you can image wider and go to the more peripheral parts of the macula. The distance between the line scans is also customizable. So it can be as low as 3 microns. Now, what is a registered scan? A registered scan is basically when you have a baseline OCT of this patient, for example, with the retinal vein occlusion and macular edema. This is a baseline scan, and it is set as a reference scan. Now, as the patient comes for follow-ups post-injections, you can see that this is used as a reference, and these are all registered scans. For example, if I see here that says 17th line scan out of 49 line scans. So 17th means that line scan, the 17th line scan is at the same position at each visit of the patient. And you can see the progression or the response to the treatment because it's a registered scan. Now, this is called a thickness map, wherein the warmer colors indicate thickening and the cooler colors indicate that it is flat or even thin. You can see the central macular thickness, and you can see on the follow-up scan, the thickness has decreased very well post-injection. This was the initial central macular thickness, 710, and now it has reduced by 430 microns to become 278 microns. These are some measurements that we have to remember. Central macular thickness and central subfield thickness. Central subfield thickness is a central 1 mm around the fovea, and these are the 1 mm, 2 mm and 3 mm circles around the fovea. So you can see the thickness maps here, the thickness measurements. This is an abnormal OCT where the central subfield thickness, that is 1 mm, is 1 mm centered around the fovea, is almost 577 microns. So this tells different thicknesses in the various subfields of the macula. Not only can we see the central retinal thickness, you can even choose to see the individual retinal layer thicknesses like NFL, ganglion cell, inner plexiform. These are academic tools for publications, etc. So these are some artifacts that can happen in OCT. So you have to make sure and beware of them. This is a segmentation artifact where the line scan is passing incorrectly through the retinal architecture rather than the ILM. Here also the ILM is segmented incorrectly. This is a mirroring artifact in a high myope patient where it's literally looking like there is a mirror image. This is because of the posterior staphyloma. Here the patient has not fixated, that's why the scan is out of registration. This is a blink or a motion artifact wherein because of eye movement, there looks like there is a retinal defect. That is a literal defect in the retinal architecture. So coming to what are the normal retinal layers on an OCT macula, this was also shown by Partho Pratim sir. And here you can see that the first is the posterior cortical vitreous, next is the ILM, then you have the nerve fiber layer. Then we see the ganglion cell layer, inner plexiform, inner nuclear, outer plexiform, outer nuclear. Then come the three major hyperreflective lines that we have to know. One is the external limiting membrane, the first hyperreflective line. Second is the ellipsoid zone. Interdigitation zone is not as important but good to know. And the last one is the RPE, which is very hyperreflective. Next, we have the choriocapillaris, then the middle choroidal layers, that is the saccharine layer, and the Haller's layer are the larger outer choroidal vessel. This is the choroidoscleral junction. Now, steps in interpretation of an OCT. This is the vitreomacular interface. We'll go step by step. Then we look at the foveal contour. Then we look at the retinal architecture. Then we look at the RPA, Brooks and choriocapillaris complex. And then if it is visible on your OCT chart that is given to you, you look and comment on the choroid as well. One more bonus is how the premacular vitreous looks. If you can just excuse me. Yeah. So interpretation of OCT is done in terms of change in the reflectance. It is interpreted as either hyporeflective or hyperreflective. Hyporeflective is, for example, the vitreous is completely dark, so it is hyporeflective. Abnormal hyporeflectivity is all fluid spaces, like the serous PED is totally hyporeflective, and even backshadowing, like you'll see in the further examples. Hyperreflective are RPE, outer plexiform layer, and nerve fiber layer. As a general principle, the plexiform layers and the nerve fiber layers are all hyperreflective, and nuclear layers are hyporeflective. Abnormal hyperreflectivity is seen in hemorrhage, pigment, scar, membrane, and exudates. We'll have plenty of examples. Now, the first step of interpretation, vitreous. You can see that there is a posterior vitreous detachment. If it is seen on your OCT chart, do mention about it. So this is another example of a premacular vitreous having posterior vitreous cells in a case of active toxolesion. So these are hyperreflective retinal layers with posterior vitreous cells seen. Now coming to the vitreomacular interface. Now vitreomacular adhesion. This is an adhesion of the vitreous to the macula, which can be either focal or broad, depending on whether it is less or more than 1500 microns. It can be isolated VMA or it can be concurrent when it is present along with another macular pathology. For example, in this case with DME, there is a concurrent vitreomacular adhesion. Coming to vitreomacular traction, it is defined as an abnormal adhesion of the vitreous to the fovea causing metamorphopsia or any structural change in the macula. This can also be focal or broad depending on size. It can be isolated or it can be along with another macular pathology where it is concurrent VMT. This is an example of a vitreomacular traction causing a defect in the outer retina, which we see as an outer lamellar macular hole. A VMT with a full thickness macular defect is a macular hole, and after vitrectomy with ILM peeling, you can see that this hole has closed at 2 months. A concurrent, like I said, VMT is associated with other pathologies like CNVM or a healed inflammatory scar or this chronic DME. Now, don't panic at the retinal architecture findings. We are just focusing on the vitreomacular interface for now. So this is a macular hole. This is the minimum linear diameter. This is the hole height, and this is the basal diameter. You can learn about some macular hole indices like macular hole index, tractional hole index, hole form factor, and types of macular hole closure like type 1 and type 2. Now this is the pre-op and post-op closure of macular hole. Now, other abnormalities at the vitreomacular interface, of course, include a large multilayered subhyaloid hemorrhage. You can see it is boat-shaped. And you can see this large subhyaloid hemorrhage causing a back shadowing, which is causing non-visualization of any underlying structure. So we have to remember that blood is very hyper-reflective at the surface and it causes intense back shadowing and hyporeflectivity beneath it. This is a sub-ILM hemorrhage, which are smaller in size, very blister-like, and cause an elevation of the ILM. Now coming to the foveal contour interpretation. So you will understand about changes in the foveal contour when you see the beauty of a normal foveal contour, which is a gentle U to V. Now this is an example of a very wide foveal contour with retinal thinning. This is a narrowed foveal contour because of contraction of the edges of the epiretinal membrane causing a pseudo hole. Here you can see that there is loss of the temporal foveal slope. And here you can see that the foveal contour is completely lost with loss of the inner retinal architecture. This is a lamellar macular hole. Coming to retinal architecture, where you see the intraretinal findings, you analyze the inner layers, middle layers, and the outer layers, and describe all your findings as hyporeflective or hyperreflective. Now, this is not a very great example of non-center involving DME. It should ideally lie outside the 1 mm. But however, you can see that exactly at the fovea, there are no changes. So this is non-center involving for the purpose of this class. And center involving is when the changes of macular edema are seen in the center of the fovea. Now, there are various classifications of OCT findings in DME, but most of them describe these findings. First is a diffuse spongy thickening, like you can see here. Second is subretinal fluid. There are some hard exudate clumps here you can see. Next is intraretinal cystic spaces. Next is hyperreflective foci. These are small microglial aggregates less than 30 microns with medium reflectivity, and they are suggestive of microglial aggregates and inflammation driven. Steroids work better for such cases. Next, you have hard exudates. You can differentiate them from hyperreflective foci because they are larger and they cast a back shadow. You can see other findings also like cystoid spaces and everything. Then this is a disorganization of the inner retinal layers. You can see that the retinal layers are well defined over here and they're completely lost here. This is called drill. Then we have degenerative edema because of chronic long-standing DME. The retinal layers split and they are bridged by these processes called bridging processes. And chronicity causes these hard exudates clumps, which are multi-layered like this. And then you have vitreomacular interface problems. This is a concurrent VMA in a case of DME. Now, last you have EZ disruption, where you can see this long-standing chronic edema with bridging processes, hyperreflective foci, cystic spaces, diffuse thickening. You can see that the ELM and the EZ till here are well defined, but here they are completely lost. I hope you can see my arrow.
Yes, we can. Yes, we can.
Yeah, thank you. So next you have ischemic maculopathy, where the vision is much lower than what is clinically explainable. And if you do an FFA or an OCTA, you can see the dropout of the capillaries and the enlargement of the FAZ. Retinal vein occlusion is an important cause of macular edema. You can see cystic spaces. It's the commonest cause of loss of vision in CRVO and VRVO. This is an example of CME in a complicated cataract surgery, wherein you can see a PCR, peripheral anterior synic A, a blob of vitreous, because of which the patient has pseudophakic cystoid macular edema. And after releasing the PAS and doing an anterior vitrectomy and a PST triamcinolone, the patient did well. So if there are two diabetic patients and both are pseudophakic, how do you differentiate between DME and pseudophakic? In DME, you will have these hyperreflective foci, you will have hard exudates, cystic spaces. These are basically accompanying features of diabetic macular edema, whereas in pseudophakic CME, there is a predominant SRF along with cystic spaces. That's how you differentiate, with no HRF and hard exudates and all that. Another important cause of CME was seen in this elderly lady who had received multiple anti-VEGF injections in the right eye and termed as recalcitrant edema. We did an FFA for her and saw a petaloid leakage. And we saw in the wide field FFA that there was capillary like ferning and diffuse capillaritis in the periphery. So this was diagnosed as a uveitic cystoid macular edema. Now, there are some conditions which also produce cystic spaces like macular telangiectasia type 2, where you can see perifoveal graying, right angle, blunted venules, pigment deposition, and these also have cystic spaces. But please remember that in MacTel type 2, there is always thinning. Now, these cystic spaces are because of loss of Muller cells like showed by Partho sir. And these are very different from CME due to other causes where there's predominant thickening. Whereas in macular telangiectasia, there is thinning along with cystic spaces. There are some miscellaneous causes of CME which are not having any petaloid leakage on FFA. That's hence they are called angiographically silent. For example, this 7-year-old boy with bilateral cartwheel appearance of the fundus at the fovea. This was diagnosed as a case of juvenile X-linked retinoschisis. Other causes include retinitis pigmentosa, Goldman-Farber, niacin maculopathy, and so on. Coming to central serous chorioretinopathy, this is a serous retinal detachment with or without PED. These you can see these small serous PEDs, and it is seen in young to middle-aged males. This is a very dramatic OCT that you might get in your chart, which you have to interpret, where there is a SRF accumulation under the retina and above the RPE. If there is persistent SRF for a long time, you can see elongation of the photoreceptors followed by thinning of the outer retinal layers. Like you can see in this case, where there, because of the chronicity of the SRF, the outer retinal layers are no longer discernible. So an AF will tell you that this has been long-standing CSC. We should know about other conditions causing neurosensory detachments, which should not be confused with CSC, like multifocal choroiditis. This case was referred as a multifocal CSC, but we did an FFA and ICGA and saw that there were early hypo with late hyper on the FFA with these geographic amoeboid lesions predominantly in the posterior pole, suggestive of APM PPE. And with oral steroids, this patient did very well. Now coming to the RP choriocapillaris complex, that is the outer part of the macula. These are hard drusen, which are discrete, small, and these are soft drusen, which are confluent and larger than hard drusen. And these are the ones that predispose to macular neovascularization. Now coming to types of PED. Now if you see a blister-like serous elevation of the RPE, it is a serous PED. They seldom harbor any macular neovascularization. A drusenoid PED is seen because of coalescing of soft drusen. These are broad-based, can have pigment on top, and these can be associated with long-standing soft drusen confluent type. Then you have a serous-looking PED, but there is a notch in the PED, suggestive of a fibrovascular component causing contraction of the surface of the RPE. So that's why they develop a notch. So the notched PED is always sinister. It harbors a fibrovascular membrane underneath it. Then the last is hemorrhagic PED, where there is sub-RPE hemorrhage, like you can see in this case, a subretinal hemorrhage causing back shadow and a sub-RPE hemorrhage causing so much back shadow. Like I said before, blood causes back shadowing. Now, there is an, depending on the location of the macular neovascularization, initially we used, just a few years ago, we used to call these CNVM. Now we call it MNV, that is macular neovascularization. Type 1 is sub-RP in location, type 2 is subretinal in location, type 3 is intraretinal in location, like Partho sir said about RAP, retinal angiomatosis proliferans. Now let us just look at what are the signs of activity in MNV or CNVM. See, this is a notched PED, right? So it's a fibrovascular PED with SRFs. This SRF is suggestive of an active CNVM. Now look at this. There is an elevation of the RPE. So it is a type 1 CNVM with scarring here and intraretinal fluid. Intraretinal fluid is also a sign of activity. Now look at this case where again there is a sub-RPE membrane here and there is subretinal hyperreflective material. This is also with some spongy thickening. So this is also a sign of activity of a CNVM. Clinically, you can see subretinal hemorrhage, exudation or fluid. Now, these are the signs of activity. Now, some special types of CNVMs are there, like pachychoroid neovasculopathy. This is secondary to a thick choroid. Here, it is special because they don't have drusen. It is seen in middle-aged people rather than old age compared to neovascular AMD. It is also a type 1 MNB and it requires fewer injections. This is a flat, irregular pigment epithelial detachment, and you can see that the choroid is dilated or thick rather. So this is the difference between a pachychoroid neovasculopathy and a neovascular AMD. See, in neovascular AMD, the choroid is so thin. It is seen in advanced stage. You can see these drusen here. And the intraretinal fluid is much more than the subretinal fluid. Now, this is a spotter that all of us know. This is an orange nodule with subretinal and sub-RPE hemorrhage and lot of lipid exudation. This is a typical case of polypoidal choroidal vasculopathy. Here you can see a hemorrhagic detachment of the RPE with backshadowing. How is it different from a regular CNVM is that it has a multilobular RPE detachment and there can be subretinal sub-RPE hemorrhage. And one more type is when there is a thumb-like polyp. This is literally a right-angled elevation of the RPE that is seen. And we see something called the double layer sign, which is where the RPE and the Brooks membrane are separated by a hyperreflective material. This is typically what we say a double layer sign. Now, last is looking at the choroid. This is important in pachychoroid, where you want to look at the thickness of the choroid, especially in the setting of a central serous chorioretinopathy or a pachychoroid neovasculopathy, and even polypoidal choroidal vasculopathy, where the choroid is thick. So I think I'm finishing at 25 minutes itself. So let's go for a revision. Simply describe the following OCTs step by step. First, we'll look at the vitreomacular interface. Then we'll look at the foveal contour. Then we'll look at the retinal architecture. Then we'll look at the RPE, Brooks and choriocapillaris complex. We'll look at the choroid and we'll look at the premacular vitreous. This is OCT number 1. So if you look at the vitreous, this is probably a low sensitivity scan. So the scan is not very good because that is also because of the refractive error of this patient. So you can see the vitreous is all right. The vitreomacular interface is okay. There is no VMA or VMT. The foveal contour is definitely lost. Now looking at the retinal architecture, here it is obscured in the outer retina by hyperreflective material. And you can see that the configuration of this eye is very peculiar. There seems to be a bowing of the entire coats of the eye, suggestive of a posterior cephaloma. So this is a very highly myopic eye with a very thin choroid, and this is all sclera. So what is happening here is that there is a myopic CNVM causing subretinal hyperreflective material, suggestive of an active myopic CNV. So the staphyloma is a clue for high myopia. Usually myopia, there is a type 2 CNVM or a subretinally located CNVM. And this is SHREM, that is subretinal hyperreflective material, suggestive of an active myopic CNV. Now this is OCT2. Now this is basically this patient in the left eye had a couple of years ago this particular finding for which he underwent surgery, vitrectomy, PVD induction, ILM peeling. And after a few years, there was this in the right eye. For this also, he underwent surgery. So what we are seeing here is that we are seeing a focal vitreomacular traction, loss of the foveal contour, and the outer retina there is a defect, suggestive of an outer lamellar hole. And here also in the right eye, we can see a focal vitreomacular traction with basically like an operculum here. And the inner retinal architecture is all lost. Only the outer retinal layers are intact, suggestive of an inner lamellar hole. So the key to OCT number 2 is that there is a focal VMT in both the eyes with the right eye inner lamellar hole and the left eye having an outer lamellar hole. This is OCT number 3. I thought I'll give you a little background just to see if you can tell all the causes of CME. So this is a 51-year-old woman having intermediate uveitis with grade 2 vitritis and snowballs inferiorly. So this history is important to tell the cause of the CME. You can go on listing the causes, say diabetic macular edema, vein occlusion, this, that, everything. But if you know the background, you can diagnose it as uveitic CME. And this patient will need steroid in some form, local or systemic. Now this is OCT4. Although it looks very intimidating, this is a case of bilateral disc edema, especially left eye disc edema you can see. And there are multiple neurosensory detachments, as you can see here. There is a large choroidal elevation and undulation of the RPE and the choroid. So please don't confuse this with CSC. When you do an FFA, you can see early pinpoint hyperfluorescence followed by late leakage in the neurosensory detachments, that is pooling. And left eye also shows early pinpoint hyperfluorescence followed by pooling. So do not confuse with CSC. Basically, what you're seeing here is that they're not simple SRF pockets. They have a bacillary layer detachment where there is splitting of the outer retinal layers that conform both to the RPE as well as the outer portion of the retina. And there is undulation of the RPE and choroid. And you saw the FFA findings. So this is a case of VKH. So take home points. Do you know how a normal OCT macula looks? This is how it looks. Do you know all the layers? Can you use terms like hyperreflective and hyporeflective? Do you know the steps of interpretation of OCT? That is, first step, vitreomacular interface, commenting on foveal contour, retinal architecture, RPE Brooks choriocapillaris complex, choroid, and premacular vitreous as a bonus. Have you seen all the slides in this presentation? You can slow down to 0.5x at any point. Congrats, you can read most OCTs. For everything else, you can just mail me at my mail ID. Thank you so much for this opportunity.
Thank you so much, Apurva. I'm smiling because most of the times, most YouTubers in podcasts, they say that you go to 1.5x for a faster viewing, and here you're advising to go to 0.5x. Okay, so wonderful talk, yes.
Thank you.
The discussion here, I would like to revolve around uveitis itself, okay, OCT and uveitis. And I'd like to bring in all of you who are present here, including Dr. Vijay and Dr. Apurva as well. So my first question would be the role of OCT in uveitis. Maybe we can go speaker wise or panel wise. First is the role of OCT in diagnosing a condition. Second would be monitoring the condition in terms of how the progression is of the disease, whether it's resolving or not. Third can be how to identify a recurrence. So I will request maybe Dr. Amit to come in diagnosing the role of OCT in just diagnosing a uveitis, be it infectious, non-infectious, or we can stick to non-infectious first. It's a huge topic, that's why.
Yeah. So can you hear me?
Yes, we can hear you. Yes.
Okay. So basically, for in interior uveitis, you want to see for any CME, it is unexplained vision loss. In intermediate uveitis, you want a CME. You may find disc edema or diffuse retinal thickening. Also, with no CME, but a diffuse retinal thickening can also be seen in intermediate uveitis and OCT. Then for pseudo uveitis, you will see the edema, you may see the lesions, and then you may see the few different layers of the retina being involved. So you can choose which layer is involved to make a clinical diagnosis, which type of posterior uveitis. Whether it's involving the inner layer or the outer layers of the choroid, and really helps you. So yesterday only the Uveitis Society of India did 2 days back in diagnosis in uveitis. Those can go to the USI site and look out for that lecture if they become a member.
Okay. Dr. Padma, your thoughts on further on non-infectious and infectious uveitis using OCT diagnosis? Some clues towards pointers. Apurva has mentioned some of them. You can modify or make it simpler.
Basically, OCT is mainly when we look at the OCT, it could be an anterior segment OCT or a posterior segment OCT. For the benefit of discussion, I'll restrict myself to the posterior segment OCT. Dr. Apurva has nicely covered, and also the way of interpretation, she's beautifully said. Whenever we look at the OCT, we need to look basically the hyperreflective dots in the posterior vitreous cavity that will help us to differentiate uveitic from non-uveitic entities. That posterior vitreous dots could be vitreous cells. And the next, you will look at the foveal contour. In the foveal contour, most of the times there will be altered foveal contour with cystoid macular edema. OCT is most useful not only for diagnosing but monitoring the response to treatment in a case of a cystoid macular edema. The next, we will see the other measures, what we use is the central retinal thickness and also the central choroidal thickness. These lesions be helpful for follow-up of cases of uveitis. Coming to your pertinent question, whether it will helpful to differentiate between infectious and non-infectious, OCT, it will help us whether you have an active uveitis or not. What are the differentiating points between infectious is when you have a taut posterior hyaloid with retinochoroiditis. Most likely that could be a case of toxoplasmosis where you have retinitis. So it could be a punctate inner retinitis, a punctate outer retinitis, depending upon the size of the involvement. So that where you have, in a case of a congenital toxo, you will have three layer signs where there is a dipping and fusion of layers and the normal retinal layers. That is a OCT appearance of congenital toxoplasmosis. Whereas acquired, you have vitreous cells and thickened posterior hyaloid, that is vitreoretinal interface will be there, and retinochoroiditis, depending on activity, we can do. The next most useful one is it helpful in necrotizing retinitis. When you have yellowish lesions in the periphery, you are not sure what it is. When we put the OCT, we could see the necrosis of the retinal layers. So based on that, we can make out it could be acute retinal necrosis or it could be a CMV retinitis. In CMV retinitis, again, we can have cystic cavern-like spaces and hyperreflective foci will be there. So in infective uveitis, toxoplasmosis, acute retinal necrosis, CMV retinitis, and as already I told in the beginning of the discussions, the rain cloud sign in a case of a fungal, or if you have a thickened RPE, that are the aspergillus moles, these two things also can helpful to differentiate. And the most important one, the commonest what we see in our practice is tuberculosis. Tuberculosis presents in the form of commonest serpiginous like choroiditis, where we have predominantly if the choroid is involved, there is a thickening of the choroid with thickened RPE with outer retinal changes and sham-like material is present and contact sign may have exudative retinal detachment. So that is helpful in diagnosing tuberculosis. If tuberculosis is varied, like it could be a tubercle, it could be a tuberculoma, but the serpiginous like choroiditis is the commonest we see in our practice.
Correct. So thank you so much, Dr. Padma. Dr. Ratnam,
Yeah.
in what conditions will you use OCT for to understand early recurrence of any infectious uveitis, non-infectious uveitis?
Yeah. In addition to what Padma mentioned, in CME, whether we have a traction or not, the OCT is very, very helpful to find out unresolving CMV. If there is a traction, we have to get help from the retina people. I just wanted to add that. And your question, can you repeat the question again?
Yeah, I wanted to ask, when do you consider using OCT in terms of understanding recurrence for any non-infectious uveitis? So, for example, VKH, like.
Yeah, VKH, obviously, as the speaker mentioned, there will be undulation and there will be pachychoroid and there will be exudative RD. And one most important one is when they are not resolving, they invariably they have subretinal neovascular membrane. I mean CNVM. Yeah. They have CNVM. So under resolving cases, in order to rule out CNVM, OCT is really important.
Correct. So one of the earliest signs which was published by Dr. Narsingh Rao in VKH for condition for recurrence was the presence of hyperreflective foci in the choriocapillaries.
Yeah. Yeah.
Yeah. I'm just talking about a patient who is. Yes, true. Yeah. Okay. Dr. Vijay, any inputs, any comments you have in terms of usage of OCT apart from what has been mentioned? Want to add any points?
I think Padma ma'am and Rathina madam has covered everything regarding the role of OCT in uveitic diseases.
Okay. Dr. Amit, we are about to conclude. Any other points you want to add? Not just regarding the OCT, but in general about uveitis to the.
Yeah, I just want to say that fluorescent angiography still has a role for looking for recurrence and for control. So at least before you stop treatment, a fluorescent angiography should be done because it's not dependent purely on the OCT.
Yeah.
Sometimes even an ICG is required. So still invasive procedures are required for uveitis. So in diabetes, you may have excluded it. Still, there's a role of FA still in practice.
Yeah, thank you. Apurva, any final comments you want to make beyond your presentation to all the viewers?
Actually, yeah, it helps that we have UVEA experts for OCT. Some of the things I have seen in uveitis, especially healed toxo lesions or healed CMV lesions, that the drape sign that we see, where there is cavitation of the retinal layers, loss of the retinal architecture, but the ILM is bridging it. That is one interesting thing that I've noticed both in CMV and as well as toxo. And we have these focal VMTs in healed toxo lesions. So is it like, if you can let me share a slide where I had a case where the patient has some subjective vision changes. I was using it for, this one. So if you can see that there is this very severe traction, focal VMT, in a case of healed toxo. So would you do anything for such cases?
Basically, if the choroidal has destroyed part of the retina, traction relieving will not lead to increase of it. They have fibril retina, they have more possibility of having a break when you try to preferably avoid.
Yeah, I do agree. We may further damage.
And in uveitic macular neovascularizations, like when there is a sequelae of CNVM in chronic uveitis, what is your pharmacotherapy of choice? Would you inject with the triamcinolone, Ozurdex, or would you go with anti-VEGFs?
If there's active inflammation like in uveitis, steroid will work. But if it's no active, that's the CNVM, then I think anti-VEGF would be preferred.
Yes.
Okay.
Coming to neovascularization, especially in uveitic, if you control with anti-inflammatory therapy, neovascularization of the disc and the elsewhere will disappear. But the choroidal neovascularization definitely needs anti-VEGF in addition to anti-inflammatory therapy. If it is active. If it is inactive, again the scar, anti-VEGF. I agree with that, the panelists.
Yeah. So I think we had a wonderful session, and thank you to all the panelists to being attentive from 6 o'clock itself, and to the speakers as well. So I want to thank each and everyone here. First, the panelist, Dr. Amit, taking out your time on a Sunday evening and teaching the residents and the fellows as well. Dr. Padma, Dr. Ratnam, once again, thank you so much for your valuable inputs. And the speakers, we had a fantastic session which had topics from starting with Dr. Vijay Tomar, discussing in detail about posterior uveitis, covering both non-infectious, infectious etiologies, and a wonderful discussion that we had further. Going further, we had Dr. Jyotirmay Biswas speaking about biologics, again a topic which is very hot, I'll say, because not many of us are using or considering biologics, and I think it is the right time to move on towards your considering biologics in your practice. Next, we had an excellent session on anatomy and the discussion as well with Dr. Parthapratim Datta Majumdar, and that is, I think, one of the best talks what I've heard in the past few days. Finally, another insightful talk on OCT by Dr. Apurva. So I won't take much time now. Sunday evening, please spend with your family, and thank you so much, everyone, and AIOS as well for this forum. Thank you so much. Thank you.
Thank you. Thank you so much for
Thank
the
you, everyone.
opportunity.